Check, 1, 2.
So, good morning, everybody. Rebecca, you guys are all set? Okay, great. So who's doing this today? Not the commissioner, no commissioner today? Okay, come on up. That's great. You're Deputy Commissioner Morrissey? Thank you. To make sure I have the right people. So, Representative Walker, do you have any opening
Good
comments?
morning.
That's about where we are these days, is we're at.
Friday.
I don't think Fridays matter.
Well, I'm trying to
don't-
give myself some solace that there's something there.
And you'll be doing stuff all weekend, just
Yes.
like me. I don't know that much matters anymore. It's, I don't think we have anybody else to
shouldn't
make
talk.
any opening comments. We should never talk. So, so we're gonna start right away. Do you, Deputy Commissioner, do you want to, say a few opening comments first, on things? And then
Thank you,
I know
Senator.
we'll dive into questions.
My name is Lisa Morrissey, and I'm a Deputy Commissioner at the Department of Public Health, and I'm here today on behalf of Commissioner Jutani. The commissioner likes to say that public health saved your life today, and you don't even know it. So much of the great work we do lies in the background of people's day-to-day lives, but the threats are now coming to the foreground more so than ever. The governor's budget under consideration by this committee reflects the need to continue and preserve the great work that we do. You have the commissioner's testimony before you, so I'm happy to start with your questions unless you'd like me to briefly summarize Dr. Jutani's testimony. And joining me today, I have our Chief Operating Officer, Michelle Schott, as well as Miriam Miller, who is the Director of Policy and Strategic Initiatives. Thank you.
Thank you. Why don't we just dive right into questions? And I'd like to talk about the local health department districts, the decrease there. And it says that we would go back to a practice of reducing proportionally the grants, because it seems to me that do we lapse dollars? Have we historically lapsed dollars in that line item? So this is a direct cut then, right?
That is correct.
And do you know what the impact would be to the local health districts if we did that? Have you talked with them?
So our teams have been talking to the local health districts, and we have pledged that we would continue to support them and increase our technical assistance that our teams are working with them on, because we know that local health departments do rely on per capita funding as well as their other funding streams. So we've made great strides into giving them assurances that we'll be continuing to support them.
So supporting them in conversation or other means doesn't really support them in funding. And so if they have to decrease what services they provide, that directly impacts the local community. And so that's why, I mean, we worked really hard to get the rates up. For a long time, they were not making what they make today. And even that was not going to allow them to do the work that we really count on. And I'm kind of surprised based on all the effort around COVID with what we expected our local health districts to do during that time frame was we put a significant amount of strain on them then. And to now say, you know, this is not appropriate. Now, I don't know that when I looked at the budget, was this a governor recommended decrease and not the commissioner's recommended decrease?
So this was in the governor's budget. And as I said, we've been working with local health to understand how this might impact them, as well as to have discussions about holistic funding for local health departments.
Okay, so when I look at the budget, you asked for the funding, correct?
Correct.
To leave it at what it was. You as an agency said to the
Correct.
governor, we need this money. We consider what they do to be valuable.
That is correct.
I'm sorry, you don't just put something in your budget because you don't think it's valuable, right? So you thought
Absolutely.
that funding the local health districts was valuable. And this $700,000 cut will directly impact communities and local health districts. So I'm really quite surprised that we have it in front of us today, in particular when we are putting so much emphasis on health and what is and then the research that's associated with this and the number of work, the amount of work that was done by local health districts with municipal sewerage to do testing and other things like that. These are things that we all consider important, and I know you do. So I'm really quite surprised about that. And then I saw the fund statutory per capita local health departments and district grants by an increase of 41,000. Was that your request or was that the governor's request?
I'm going to give that to Michelle Schott. I believe that was for new districts, but I'll give that to Michelle. It's new districts. It's towns joining districts, so that's an increase in the per capita cost.
Could you speak up a little bit?
I know you're
Sorry, I'm
soft-spoken.
I'm soft spoken and I my voice is pretty raspy, so I apologize.
Say to the kids outside voice.
So I was saying that it's a reflection that we have towns that have recently joined districts. So it's an increase because we have towns that joined districts and they weren't previously eligible for per capita, but now that they are.
Okay. Thank you. And then, when I look at, um, the needle exchange and the children's health initiatives, are these all, general fund or are they insurance fund dollars? Do you know?
I think those are insurance fund. Those are insurance fund.
It, no, it's right here as insurance fund. It's, it was
Those are
general
insurance
fund, but
fund.
they moved it
No,
out.
sorry.
So if we were going to move things over to the general fund, because we all know that a lot of the things that are in the insurance fund, Representative Walker and I were on a task force that, where we learned a whole boatload about insurance. Not that we necessarily liked learning this much about insurance, and then here comes Representative Nuccio.
Who was on that same task force.
Who was on the same task force. Who
Like,
knows
what
about?
Who knew
Um,
everything that we were.
So if we were gonna move some things over to, back to where it originally was, which was the general fund, these are the dollar amounts that you would consider, necessary for us to move over.
That's correct.
Thank you. Representative Walker.
Good morning, and thank you for coming before us and everything. So there are a couple of things that I also want to sort of echo the local health departments. I mean, we have a lot of things that municipalities and towns do that we help navigate. And in what this reduction does is it basically says we're here to listen, but you're not going to be part of our team. Is that kind of what I'm getting with the reduction? I know I'm tired, so I'm trying to navigate the words too. I'm trying to understand what was the impetus to reduce this? And maybe I didn't hear Senator Austin. This was not your recommendation. This was the governor's recommendation. Is that correct?
So I'd like to say that for those who don't know me or my background, I'm particularly sensitive to local health, as I was a local health director for some of our largest municipalities, as well as some of our smallest rural municipalities in the state.
Come a little closer to the mic.
And so when we talk about impacts to local health department, and particularly, that ones that they experienced during COVID, I'm pretty familiar with those because I live that. So I am sensitive to the fact that there is a cut. And I'm also sensitive to the fact that the budget that's put forth is a best picture to try to preserve as much public health as possible, and that there has to be some median there.
Okay, all right. I think in the group, we'd like to get a little handle of what is the exchange that goes on between you and the local public health departments, because if there are things that you are requiring the local public health departments to provide you, we need to find out what they are so that we have to pay for them, because that's something. So I just want to get a little deeper into what are we losing by this and what do we need to replace. Okay.
Absolutely, that's understandable, and we're happy to prepare that.
Okay, thank you. Going on to the next is in the ARPA budget, we had grant for scholarships for people who are studying in the health area. Do you know how much of those dollars went out and how many people
Michelle, can I give that to you?
participated in that?
We can get you that information for the subcommittee.
Okay.
And what exactly are you looking
Could you
for?
do me a favor? Could you state your name, please?
Oh,
and
I'm
what
sorry,
your
I'm
title is?
Michelle Schott, the Chief Operating Officer.
Okay, hi Michelle, go ahead.
Hi. So what exactly are you looking for? So we can make sure we get it.
There were,
appropriate?
I thought, 2 funds that were scholarships for people in the health areas. One was for nurses and another was for specialists of some sort.
Okay.
And they were started with the ARPA funds. And we tried to, for a while, there wasn't any accounting, and we needed to get the accounting of how many people participated in it and how much money we distributed through the ARPA funds.
Okay, we'll get that for you.
Okay, all right. Then there was also money that was set aside for lead abatement in housing. And that was a sizable amount too. And we never got an accounting on that. And we'd like to know what we got and how many houses, and are we still doing it? And has it been annualized into the budget, et cetera, et cetera. So we need to know all of those funds all of those major ARPA funds that were paid out of the ARPA, all of the major public health funds, ooh, this is gonna be a long day. All of the major, just give me time. I'll get to it. All of the major funds that were paid, issues that were paid out of ARPA for public health, we'd like to get an accounting of where they are and where they're standing, whether they're being incorporated into your budget and annualized, or whether it's cut off now and the existence is not anymore, okay?
We're happy to prepare that.
Okay. The next one is the gun violence prevention. It started out at 700,000 in 24 and it's gone up considerably. So could we get a breakdown of what are the things that we are paying for in that line item?
Absolutely.
And I know that there is some evaluations for the programs. Could we get what those are doing and what's expected going forward?
We'll include that in our response.
I'm sorry?
We'll include that as well.
Okay. And I think that's enough for me. I'll shut up. Thank you.
Representative Dillon, followed by Representative Nuccio, followed by Senator Marks.
Good morning.
morning.
I have I guess a concern about the changes that I see in the funding for AIDS prevention and I don't, I'll look at the dollar amounts, but it includes a cut to state services as well as federal, am I right?
Yes, it includes a cut. The current budget includes a cut. We typically surplus funds in our AIDS prevention. So this is just reducing us to our current spending rate. This will not have an impact on our program.
With all due respect, and there may now be and will be pressure on your department given what's going on in the federal level. I know people who cannot reach the CDC site. There was a whole network of us scrambling to see whether we could archive files because they were being wiped out. That was also happening in NIH. I don't know what kinds of functions we've taken for granted that may be zeroed on the federal level and whether or not there will be an expectation or a desire for us to pick them up on the state level. And so I'm very sympathetic to the situation that you're in. But I'm very concerned about AIDS as well. So if you could follow up for the work session with an explanation about the AIDS dollars, because obviously everyone's watching it because of the controversy in Washington. And second, maybe is there any do you have a plan and are there preparations for any potential change in our eligibility or our total dollars from the federal? That would be, and that's a big thing in your department, or that would be less helpful because it affects our revenue. Have you done that yet?
So I'll take that one, Michelle. Thanks. So right now, there's a lot of uncertainty what's happening with federal funding. So we haven't had any indication from the federal government that our position will be changing. And as far as taking a look to see how this could potentially impact us, you know, that ratio that you're referring to, our team has not indicated that it would adversely impact that ratio for that contribution. There we go.
Yeah,
Sorry.
if you could just speak more direct. Thank you.
Yeah, I moved it a little bit. I apologize. So I was saying that to the two pieces in your question. So one, with the uncertainty right now with the federal government, we have not had any communication from them as far as changes to our federal funding level. To the second piece of the question, that was directly related to if we had a reduction in the state contribution, how might that potentially impact our federal contributions, which I think your question was to me. Our team has not indicated that they have identified that there would be any adverse impact to the federal funding.
Okay, well, going forward,
Okay.
thank you. Going forward, it seems that we're gonna have to have a plan to identify everything that, there's scrambling going on in states all over the country to try to understand the impact of the chaos in Washington. And so, and clinicians are worried about it. They can't access what they need. So, we may have to be the little red hen here and figure out either how to cooperate with other groups to get things done. But any information you could provide the work group would be very helpful.
Happy to
And
do so.
that's it. Thank you.
Next is Representative Nuccio, followed by Senator Marks, followed by Representative Gilchrist.
Thank you, Madam Chair. So I'd like to talk about a couple of things. Rep. Walker brought up the growth in gun violence prevention, and I second that. I'd like to understand what that growth is. I know it happened in 2025, so we should probably kind of look back and see what got thrown in there. But my bigger area of concern here is definitely the reduction to the local health districts. I had my health director reach out and say just and Representative Walker again mentioned like the lead abatement program, but the childhood lead poisoning intervention threshold reduction that was put onto the health districts. In my health district, they're saying it's increased their workload by 500%. So this cut here, any details that you have on that, I just can't find myself being supportive of cutting them at this point. As you mentioned, being a prior health director, I think this is going to be pretty detrimental to their budgets. And then the only other question that I had is there was also then a fund statutory per capita local health district grants going up 41,000. Is that just a statutory increase on top of like it never makes sense to me why we cut something by 700,000 and then we give them 41,000. Do you know what that one is being driven by?
The new towns have joined health districts, which makes them now eligible for per capita when they previously weren't.
All right, so these are new towns.
So that there are towns that previously weren't in health districts that have joined a health district, meaning that they're now eligible for funding.
Okay, all right. I think that is all that I have for right now. Thank you very much.
Thank you. Senator Marks, followed by Representative Gilchrist, and then Representative Walker and I have more questions.
Thank you, Madam Chair. Welcome. So going with the local health districts, I think we're all a little surprised with that. I don't just echo what's already been said. Can you explain the immunization services? It states in the backup that you anticipate a drawdown of existing vaccine stockpile. I think we're all having a little anxiety about vaccines. So can you just explain that? And if you're anticipating it, if that anticipation is wrong, what the plan would be?
Certainly. So we currently have enough vaccines in our stockpile right now that we can utilize that first before we need to purchase additional vaccine. So that's really describing the fact that we took a look, that we had an internal committee that was really reviewing the vaccine utilization, how much vaccines we actually had access to, and how much additional we needed to budget for. So we're really just saying that we are now trying to use up that stockpile before purchasing additional.
Okay, that's a makes my heart not beat as fast answer. And then as far as the federal government, we're all very anxious about that too. I don't know how much money the Department of Public Health gets from the federal government. Is there a big number you could tell us? And could you also maybe send us some information about how much break down that money that we get from the federal government?
Certainly. So I can, excuse me, I can do some broad brushstrokes right now and then happy to provide additional information at a later time. So roughly right now, roughly 80% of our funding coming in from to the agency from the federal, sorry, roughly 80% of our funding is through the federal government at this time. We do anticipate that that will be dropping significantly, not necessarily because of these changes, but more so a reflection that a lot of that funding was for COVID. So as the COVID funding runs out, that percentage will shrink.
Okay, okay, and does the immunization to purchase vaccines, is some of that through the federal government?
That's correct, but I don't. It is. Yeah, yes, it is.
So wouldn't we be better off to purchase now before they take it away? I mean, I'm not, I don't want you to look at my checkbook, but I think I think we should do anything that the federal government is funding. We should like buy everything now while we can when they're still helping us before they take it away. So that is the nurse and mom and me talking very economics 101.
So yeah, yeah. So my name is Miriam Miller. I'm Director of Policy and Strategic Initiatives for the Department of Public Health. The number of vaccines we can purchase on the Vaccine for Children's program, which is what the federal government, that's the component that the federal government pays for, is limited by population, right? And so we can't necessarily stockpile vaccine with federal funding, but the vaccines themselves aren't going anywhere. Right, the mandates for vaccines and whatnot, the commissioner still has the right, basically through statute, to set the vaccine schedule for schools. So that's not necessarily at threat, but the funding might be jeopardized. And Michelle, I think, has another comment to add on that.
Just really quickly on federal funds are done reimbursable. So we have to spend the money before we get the money from the feds. So we cannot just say, hey, can you give us our $1 million you want us? We have to spend the money first.
Do you have to spend down, do we have to use up the stockpile? Is there only a certain amount of vaccines we're allowed to have in our reserve?
No.
So I
No.
still don't understand why we're not going to buy some now with them helping us.
But
I'm sorry, can I ask a question?
Sure.
Don't they have a shelf life?
Yeah.
so our inventory is virtual. It is not like you're not going to walk into a warehouse and see all
Thank
the
you. I had
vaccines
to
there.
understand that. I'm sorry, Senator.
Yeah.
No,
so it
that's
is
fine.
virtual.
Okay. All right, let's just be smart.
We
Okay. Thanks.
will, we promise.
Thank you.
Representative Gilchrist, I had Senator Summers come on, so I want to go to her and then I'll go to you. Senator Summers, followed by Representative Gilchrist.
Yes, good morning. I'm sorry I was a few minutes late. I had another meeting bouncing here. I have a few things. First of all, I would not be able to support the cut to the health districts. They do amazing work, and I think that it is important that the state supports them. We rely heavily on them. I would like to see if you could provide us with the funding that we have received from the federal government over the past 5 years and what our expenditures have been to get those federal dollars. And I would like you to separate it by COVID dollars versus what we typically would see, pre-COVID, so that we have a baseline to really look at. The other thing I would like to say is, we don't know what's going to happen with Washington, and I'm really getting tired of hearing that the sky is falling. I think we need to provide an opportunity for this administration, whether you like them or not. They haven't even been in office for 1 month, and to see where everything shakes out before we say that we have to, stockpile and buy all this stuff. I think that that is not a rational way to approach this budget. The third thing that I am concerned about is, and I'm not sure if the commissioner is aware of this. To me, it's a conflict of interest. I'm not sure if it is to anybody else. On our committee that we have for the prevention of gun violence, 3 of the sitting members on that committee have received grants from those dollars. And I just find that a conflict of interest. If you're a member of a committee, I think that that is something that needs to be looked at. I wanted to make sure that she's aware of that. I have the list of the people and I'm happy to share that with her and everybody on the committee. But I think that's definitely important to note. If you are on another committee, if I sit on a committee, I would not be the recipient of a grant that committee is adjudicating. I'm not sure if she's aware of that. I wanted to make sure that that is something that is brought to her attention, and I would be happy to share the list with all the committee members and with the commissioner herself.
Senator, you might as well say it because you're just going to be asked to say it and the press is listening in. So who are they now?
Okay, I didn't realize the press is listening in. I have the list of the Connecticut Violence Intervention Program. That would be Leonard Jihad. The Compass Youth Collaborative, which is Jacqueline Santiago Nazario. And the third one I have, oops, hold on here. Sorry, give me 1 second, is the Greater Bridgeport Area Prevention Program. I have no problem with people getting grants. I just think it's a conflict of interest if you're sitting on that board deciding who gets the grant and you're the one that receives the grant. So I just want to make that clear.
You have to look at the process on how they're doing that. So thank you for that.
Thank you. And that's, I will have more, but, I think it's very important on our health districts, especially, we continue to add work to them, and to, reduce the dollars or to have the dollars go further just does not make sense to me whatsoever. So I just want to let that be known. Thank you.
Through the
Thank-
chair, if I may, I'd like to just clarify one point on that. So I just wanted to clarify that the members of that committee do not make decisions about who's receiving the grant. The Department of Public Health does. So I don't want there to be a misinterpretation that the organizations that are on that committee are making decisions about who's getting that funding.
Thank you.
Thank you for that. I still think it's a conflict and I would like to understand the process more, in more detail. Thank you.
Happy to provide that clarification too.
Thank you. Up next is Representative Gilchrist.
Thank you, Madam Chair. Good to see you.
Thank you for your
Good to see the whole team. So my first question, well, actually, I'll start with, as a follow-up to the gun violence prevention, when you bring us that information, can you also include any ARPA dollars that had been put towards the funding? Just want to understand what's going away.
Okay.
Thank you. My question has to do with Haven. So with that section of the budget, I'm a little concerned just because shifting of the dollars to the opioid settlement fund, there is an advisory board that would have to agree to that. So what I'm interested, and then another concern, I'm excited about the reduction, or I guess it's the total elimination of certain fees for certain occupational licensure. Then I know we also have done these compacts with other states, which was going to potentially impact the revenue going to Haven. So could you do for the work group a breakdown of all the various occupational licensure fees that go currently to cover Haven, the ones that are then being eliminated and the ones that are involved in the compact, just so we can get an idea of how much Haven has been getting and where they might be potentially losing funds going forward? Okay, thank you.
Thank you.
All set. Representative Pavlik D'Amato for the first time.
Thank you. And I was just going to add about the Gun Violence Prevention Commission. That commission, along with, I've noticed this with a couple others, I think it was rare disease. I've looked for their minutes in order to obtain some of that information. And with the gun prevention, there's no minutes after 2021. And I also, like I said, with the rare disease, I can't find minutes to even look into those things. So I think if you look into that, when you get those figures, if you can ask them where their minutes can be found, that would be helpful. So thank you.
We do have a working group website that we can send to the committee that would provide that information.
Thank you.
Thank you. And you all know that everything goes to Susan Keene and then comes out to the rest of us. Representative Walker, there was somebody else who had their hand up that took it down, but I'm not sorry, not you. It wasn't you, it was someone for the first time and I didn't write it down right away. But Representative Walker.
Thank you, Madam Chair. And I wanted to, I was going to say in the last, but I said I'll come back around. On the opioid settlement funds, the money that is identified for Haven was $725,000. But in the governor's budget, he's asking for allocation because, as my good colleague, Representative Gilchrist pointed out, that it has to go through the opioid settlement board, and it has to also go through the alcohol and drug committee too. So the fact that this is put into the governor's budget, unfortunately, does not supersede the process that has already been set in place for any of the opioid settlements. So I just want to make sure that it's understood in that regard. And then the other part of that, I was going to ask for the same thing on the licensing too, because I will say that one that was very glaring to some of us was the fact that social work was not listed in there. And that was very disturbing to us. And we have so many needs for social workers in the state, and we're constantly looking for them. We want to encourage them, like we want to encourage nurses and we want to encourage teachers. So I think it's really important that we do that. And then the other thing is the cannabis fund. The cannabis fund in here, the governor's transferring 468 in 3 positions in 26 and 27 into the general fund. Why?
I'm going to give that to Michelle Schott.
So the cannabis fund is a regulatory fund, and all our regulatory duties that we do in the Department of Public Health come out of the general fund. So we're just aligning it to where our regulatory costs are.
However, there is a tail to that regulation. It affects the cap, and it affects funding in other things. So it's very interesting when we pull those different definitions out. So I am not in support of that. I am not in support of moving the cannabis fund back onto the general fund. I think it needs to stay where it is, and it does not need to have impacts on other agencies in getting funding that is so desperately needed. So I'll just say that.
Thank you.
Thank you.
So I'm going to go in that same vein relative to the cannabis fund, but also relative to the opioid settlement fund. The money that they have allocated in this is off budget items that we're supporting Haven, and the 16.1 million in 26 and 18 million in 27 that the governor is allocating out of the opioid settlement fund. It's off budget. Neil, is that off budget? It's off budget. So the governor has 16 million off budget here, 300 million off budget relative to the child care fund that I know you don't care about, not your forte. You may care about it, but
It's not in your realm of.
it's not in your realm of thing. But I think that that's interesting, that we have these off budget accounts when we're told that we have to maintain a certain amount of sacrosanct fidelity to the caps, but this is not maintaining fidelity to the cap relative to the opioid settlement fund money of 16.1 and 18. And when I read this, additional allocation for Haven is done. And could you describe what Haven is? I think I understand it, but if you could describe what Haven is.
I'm going to turn it over to Miriam Miller, who's been working more closely up with this than I have.
Good morning, I'm Miriam Miller. Haven is a organization that helps people who are licensed professionals in the healthcare industry return to work should they have been found to have any sort of challenge, be it alcoholism, drug use, mental health challenges that have pulled them out of work due to disciplinary action. Haven is a program that helps them get back on track to re-enter the workforce.
And is that like a confidential program? And is it a nonprofit?
I believe Haven is a nonprofit, and I think that it's confidential to the extent that the interactions are confidential, but the fact that they may have gone to Haven may be on someone's license.
So is it relative to, can you get us some more information on that? Because is it like AA or NA or anything
No,
like that
it's-
as
it's different.
more anonymous than
Yeah.
anything?
It's going to be a little different because there's actual like drug testing or alcohol testing requirements or certain requirements around getting treatment for the reason that they entered Haven.
Well, I've long been a supporter of Haven. I
Yeah.
think it's very necessary to have something like that in the healthcare field, which has significant stressors relative to drug and alcohol abuse and other things.
Yeah.
So I'm not opposed to that. I would just like to understand a little bit more and recognize that this is an off-budget account that we're establishing for Haven and for other areas relative to mental health and addiction services, children and families and housing, and public health. So I'd like to understand what other off-budget line items the programs are we funding?
Okay.
Again, I'm okay with funding some of them off budget.
Mhm.
I just want to recognize that it's happening in this budget. And so when I hear it at the end of this budget, I'm going to say it's exactly the same thing that happened.
Yeah.
So.
And so Haven is partially funded through the licensure fees that people pay. So I think it may have increased last session, but at least $5 from every licensure renewal goes to Haven. And so the reason that there's this addition to Haven is because we're cutting the licensure fees. So it's to supplement the
Yeah.
cut in the licensure fees.
I understand that.
Okay.
I'm very happy that we're reducing licensure fees for certain professions. I think that that's appropriate. And the connection between what we supported with those licenses should be in the same line item. Reducing a licensure fee has led us to need money in this line item so that we can address that, because we want to support the programs that we have been supporting under licensure fees. But this is the same problem we had when the federal government decided that they were not going to support VOCA, the Victims Against Crime Act. And they have not seen those fees and fines ever get to the level that they were before, leaving, if we believe in those programs, the requirement for the state to backfill some of those. And it puts us in a position where we're not being able to fund the programs necessary for good governance relative to things. And Representative Nuccio, I have Representative McCarthy-Vahey for the first time, and then back to you. I'm sorry, Representative McCarthy-Vahey.
Thank you very much, Madam Chair, and thank you to the department for being here before us. I think there have been a lot of great questions, and I would align myself with the comments we've heard from the chairs and others and our ranking members, just the concerns about the local health district funding, the concerns about the opioid settlement funds being used, and the federal funding conversation that was happening earlier. One additional question that I would have is, the 80% number that you cited was a COVID number. If we could understand the federal percentage from pre-COVID to now, if that is something, if you have that now, I would love to hear.
Certainly. So in broad brushstrokes, it was roughly about 50% pre-COVID, but it sounds like there was a question earlier about doing a 5-year look back. So to better understand what that nuance looks like. So we're happy to provide additional detail then.
Great. That would be wonderful. And also, I recognize, as our good ranking member on appropriations and public health was talking about, how we talk about what's happening with the federal government. And it's my understanding that you will continue to communicate with us as information is received so that we can understand exactly what we do need to do and be able to respond appropriately. And I see you nodding your heads to say yes, that is the case.
Absolutely.
All right. And I know we will be having other conversations in the future, so I will leave it there for now. Thank you, Madam Chair.
Thank you, Representative Nuccio.
Thank you, Madam Chair. And to kind of continue on with what Representative McCarthy-Vahey was just saying, I'd appreciate it if we actually communicate what we actually know and not innuendo and rumor. I would like to know what is actually coming from the federal government in communications. I agree we have to have ideas in our head if we get cuts in certain places, but the whole, running around trying to do all of it now doesn't help anybody. And going back to the immunization, just because I'm intimately aware of this part here, this is funded through the insurance fund, right? This is funded through an assessment through the insurance companies, right? I didn't think there was any federal dollars on that. I understand it is a purchasing plan that we virtually, like you said, buy them in bulk, but the actual cost of those immunizations goes through the insurance fund.
Yes, for some, there is some that goes through, I'm gonna let more, Miriam talk about it, but there is some that goes through the children's immunization.
Right, there's an adult and child, is the whole immunization fund, adult.
Yeah,
side,
yeah.
Everybody in the state of Connecticut, every belly button gets hit with $47.09 a year in their insurance costs, yes.
So the Connecticut vaccine program is kind of broken up into two programs. There's the Connecticut vaccine program and the Vaccine for Children program.
Yep.
The Vaccine for Children program is the federal program that covers children who are on CHIP, who are uninsured, underinsured, or who are on other kind of federally supported health plans. So the vaccines for those children are paid for by the federal government. Connecticut made the decision several years ago to broaden the vaccine, to basically make that program, the Vaccine for Children program, available to all children in Connecticut. So the kids that are covered under the federal programs are paid for by the federal government, and then the state fills for all other children.
Right, and that's how I understood it. It's all through an assessment, so the federal government is not paying for the majority of these.
No, they're paying
Insurers
for-
are paying
yeah.
for them, correct.
Yes.
And also.
Well, the federal insurers are paying. It's federal.
Well, actually, it's all
and-
the insurers. It's all of them.
Okay,
Yeah.
it's an assessment.
But, so looking at that there, as you mentioned, it was 26 million. That was an oddity. And it was because there was such a large stockpile.
Correct.
Right.
Correct.
And then going back up to the 60 million, 50 million range is what we've historically seen for the last over a decade from the immunization costs. As other shots have come on, it has gone
Mhm.
up, but that is our regular incurred amount. And the majority of that is paid for through an insurance assessment that actually hits every insurer in the state of Connecticut, correct?
Correct.
That's what I thought you were gonna say. Thank you. And I would also just kind of like to understand from the Haven program, is it 100% funded right now through the costs and the licensure? I see you shaking your
Yeah,
head. No.
no, it's a partial.
It's partial. Okay, so can we get that breakdown between what is covered through the licensure, what is covered through the state budget? And also I would like to just know, like the total cost of the program and how many people it's serving. Because you said it's a nonprofit that's doing this, correct? So I would like to understand the actual population that's being served.
Yeah, we'll see if we can get that information. We have how much we're paying Haven, but we'll have to work with Haven and see if they will give us some of that information.
I would hope they would. It's non-PHI, so we're just looking for a total number, but I'd like to understand how many people we're serving and what the cost per person is.
Okay.
All right, thank you very much.
Are there any other comments or questions? Representative Dillon?
Thank you, Madam Chair. Not to belabor the point, but on the Haven, if you could get us more background on that. I mean, we're choosing to take dollars to cover that program because we're choosing to forego the licensure. Now, I obviously support the licensure, I guess, but physicians in Connecticut have no duty to treat, right? So they don't necessarily even take Medicaid patients, am I right?
That's outside of our purview, so I will have to defer.
Right, I just want to, when we look at the narrative that says to maintain services, we're maintaining services to a group of clinicians. And it's probably run by people I know. I mean, so I'm not trying to be personal about it. I'm just looking at a policy level of we're doing a pickup because we're taking away the fees. But we're not expanding services to people who aren't getting healthcare in the community, am I right? It's simply continuing services to a particular group of physicians.
Sure. So I'm actually gonna, Miriam, do you want to come and talk about that a little bit more?
I have very short legs and this is a high chair. So Haven is not necessarily like a healthcare service. So we're maintaining service, but the level, like maintaining kind of level funding for Haven. And it's not necessarily an effort to expand services, but it's allowing them to maintain the work that they're currently doing. Does that answer your question?
Well, it doesn't, I guess my final question was, and I know that we're gonna do this again, is, and I don't want to make you bop back and forth too much.
It's
but,
okay.
but you're in pretty
Yeah.
good shape. I think you're doing great.
Thanks.
But we're not expanding services to people who are currently not getting clinical care.
So-
We're continuing services to a particular group of clinicians who, am I right?
So
Who don't necessarily serve the uninsured or Medicaid.
So I think that that's probably a bit of a little scope creep of the purpose of Haven, which is to make sure that all healthcare providers have resources they need to re-enter the workforce. And it's making sure that they can get back into the workforce regardless of where they're working. And this is not necessarily an effort to, Haven is not necessarily meant to, look at the provider shortage or anything like that. It's really meant to help healthcare providers get back to work if that's where they want to be.
No, thank you. No, I'm just trying to understand the choices that are being made in the budget, but thank you very much. Thank you.
Senator Marks.
Thank you, Madam Chair. How many positions do you have in the Department of Public Health, and what's your vacancy rate, and how long does it take? How's the onboarding going?
So we've made significant strides with trying to fill some of our vacancies. We currently have 404 filled positions. We have our authorized count is 481, and we have 77 vacancies that are not funded. That's correct.
So are all of your funded positions full?
That's correct.
Wow, good job.
All set?
Yep.
Senator, all set? Yeah. Representative McCarthy Vahey.
Thank you, Madam Chair, for the second time. A question about communication. And we know that with a third of the country, I think, at one point on TikTok, I'm not, but and social media being a way that many people receive news and information. I have been in conversation with some of the leaders from public health about how we are communicating messages. I know some of our local health districts do that. For example, information about the flu shot and the safety of the flu shot and the importance of getting the flu shot and things like that. What plan does the department have for being able to help communicate out public health messages, both through official channels, but messages that the public can rely on as really based in settled science?
Thank you for the question. It's actually one that we've spent a lot of time internally working on, particularly since we recognize the importance of having credible public health information. So there's multifold strategy here. So we've been working to build out our marketing. We call it MarCom, marketing and communications. And that's really kind of recognizing the need that we have a responsibility to do crisis communication in addition to what we consider the bread and butter communication around chronic diseases. So we've been building out that team as evidenced by our vacancy numbers dropping so that we have all of our funded positions filled. In addition to that, our team has actually, we've consolidated how we've been working with local health departments as well as our community partners to have a better understanding as to what type of support and how they would like to work with the health department as far as resources. We recognize that particularly for our community-based organizations and local health departments, they may not have full marketing communications. They may need help with developing campaigns. They may need help with developing those social medias. So that's really where we've been trying to realign our efforts. So we're not just communicating about the great work that DPH is doing, but what do our communities need, and what recognizing that every community's communications and their needs looks a little bit different, and being able to provide them that technical assistance and resources.
Thank you for that. I have been exploring the idea of kind of recruiting grassroots providers to help expand the messaging. Because again, we know that people trust those who are closest to them. So I look forward to further conversations with all of you about that. Thank you again, Madam Chair.
Thank you. I just want to piggyback off of the good House Chair of Public Health. Communication is something that we all depend on, and I think we are all in a very new method of communication. I know we've talked about being careful about jumping to responses to things that we're hearing, but when there is no real formal way of communicating to all of us about things that are adjusting, except for through the news and media, it makes it very, very uncomfortable and tenuous. So it's very hard to map out where we need to go. And I don't think we're being sensationalizing. I think we're responding to, are we okay? Okay. Okay. But I think we have to be very aware of what is being said, and we have to pay attention because we're never sure which is an actual fact or which is just a threat. So I think the most important thing is always be focused on all of that. So thank you. Thank you for that, guys.
Representative Kennedy, and just so you guys know, we have Representative Nuccio says she's not online right now, and that we have Representative Nuccio showing up online. Can we find out who that is, please?
Not me.
Representative Kennedy.
Thank you, Madam Chair, and thank you for all of your work today. I just have a question for clarification, and thank you for the information on the number of positions and the vacancies. So just for clarification, in the Department of Public Health, there's a Director of Policy and Strategic Initiatives, and then in Department of Developmental Services, which we're going to hear from next, there's a Director of Policy and Strategic Initiatives. Is that a typo, or is that person share between the two departments? Or I might have a typo on my sheet.
So
I'm
I
just trying to-
can't speak for the other agency, but I can say that, yeah. Yes,
Yeah.
but
Okay,
yeah,
I just-
it's not a shared person.
It
Miriam is
might be a
full-time.
typo, but I was like, how is he
Yeah.
working in two, and
Yeah.
I'm sorry, I don't mean to call that person out, but I just wanted to clarify that it's not.
Oh, okay.
There's
Okay.
3 of you listed in 2 agencies.
Oh.
Okay.
Yeah.
You guys are
I was gonna
busy.
say, wow, you guys are busy, but thank you.
There's 3 of you listed
Okay.
as two. I
appreciate it. Thank you so much.
Somebody just copied and pasted, that's all.
Thank you, Madam Chair.
Sorry for
you.
the confusion.
We'll make sure you get paid for all jobs.
No. No, she is making sure that is not,
I'm
no.
thinking it's optimization, using skills across multiple areas.
Job share.
Okay, any other comments or questions? Seeing none. You're all set. Thank you very much for coming. We gave you a long list of things to bring back to us. We really appreciate that. You can send them ahead of time so we can look at it. It would be really great.
Thank you. And thank you for the opportunity and your time today. Thank you.
Thanks. We have, up next, do we have the Department of Developmental Services here?
We can take a 5-minute break.
Okay, we'll take a 5-minute break as we figure out where we're
Nope.
going next.
They can sway it though, right? Because they're on the.
Good morning, Commissioner.
Good morning, Senator Austin. How are you?
I'm good. How are you?
Terrific.
Is everybody here with you that you need?
Yes.
Okay. I'm just letting you know you have the least amount of staff of any agency. I'm certain that they're back there doing business, so that's a good thing.
I'm glad to hear that. I was worried my entourage was a little bigger than last year, but I will take that as a good-
No, it may be a little bigger than last year. And we added some DPH workers into your staff, so use them anytime you need.
Thank you. I appreciate that.
There's 3 of them. We decided that they're working for 2 agencies. We're not certain what they're doing, but they're working for 2 agencies. We didn't wanna, you know,
Deprive anybody of.
No. So, Commissioner, do you want to make any opening statements before we go into questioning?
I just wanted to thank you for the opportunity to be here this morning. You have my written testimony and I'm ready to go when you are. Thank you for having me.
Thank you. So, the PCA collective bargaining agreement that money is put in the budget for, is that agreement until 2027 for the PCAs? Do you know?
So the agreement goes through fiscal year 26, and then in 27, we don't have extra agreed upon wages at the time, but certainly we'll look at a new CBA at that time.
Can you
So-
introduce yourself?
Oh, sorry, I apologize. My name's Nicholas Gerard. I'm DDS's CFO.
Thank you. And so, because there's money added in both years, for the collective bargaining agreement, is that second year just annualizing the salaries from the year before? Is that what that would be?
That's correct. And if you notice, there's a little less in the second year, and that's
Yeah.
because there's a specific payment that happens in fiscal year 26, like a one-time payment that doesn't happen in fiscal year 27.
Thank you for that. And, do you know how many people this covers in this collective bargaining agreement?
I do not know the number. It definitely covers multiple agencies, and we're happy to get you the DDS numbers.
Thank you. I appreciate that. And I'd like to go to Southbury because it's my perpetual question on Southbury. Can you please tell me how many people are left at Southbury as residents?
I apologize. We're around 90. We have 6 or 8 people moving off the grounds, and I'm not sure where they are in transition. But we are below 100. And I think we will be at or around 90 on the grounds shortly.
And how many buildings do the below 100 people take up?
We take up a lot less space than we used to. The buildings remain on grounds that are empty. Some have been mothballed, the ones that we don't use, and we announced another closure, or in the budget include another closure. Our goal is to continue to downsize our footprint there, and we are in partnership with other state agencies figuring out future use of buildings and grounds there.
So the 6 to 8 people, would that bring us down to in the 80s, or does that
To
bring?
around 90?
Not, that 6 or 8 brings you down to around 90?
Yes.
And how many staff are still there total?
I can get you that number. I don't have that number off the top of my head.
That would be helpful because I'd like to understand that and the number of buildings that you are associated with. Now, with the DDS population, my understanding is that, thank goodness, the DDS population is living longer, but there's an early onset dementia that happens in younger ages of people with DDS, is my understanding. What is going on relative to that? And do we have housing that will be able to assist with housing for a DDS person who has dementia?
So thank you for the question. Over the last number of years, we've issued some guidance as we are assisting people aging longer on average every year. Our mortality age increases. But included with that comes comorbidities that we didn't have to face before, as you've suggested with the dementia. So we do some specific training, and so that in our group home structures, there's someone oriented to those changes that occur for people, signs and symptoms of onset of those types of issues. And we have, there are some agencies who have some specialized training around that. We do have opportunities for individuals to live in the community with those ages. We don't operate currently, I think you've seen in some of the long-term care facilities, they'll have locked dementia wards and things like that. We don't have a facility for that. So there are times when someone reaches a point where they need some other level of care that we can no longer support them, but it wouldn't be very different than the general population.
So saying that it wouldn't be very different than the general population is one thing, but the general population is seeing a decrease in nursing homes out. I talked to this because my mom had dementia, and my mom was the youngest of 8, and all of her brothers and sisters died from the complications of Alzheimer's. And so it's very prevalent in the family. And we needed to have specialized care for her based on her dementia. Someone who has developmental disabilities may have a different higher level need when they are suffering from the complications of whatever form of dementia they may end up having, because Alzheimer's is only one, right?
Mm-hmm.
So has it ever been thought of to look at Southbury housing structures for anything else beyond trying to close it down as soon as possible?
Thank you for that invite. My goal would not be to see the campus shuttered completely. Just within our population there, including input from the remedial expert who oversees the Messier agreement and has overseen transition to the community for dozens and dozens of individuals, that there are some people who would need the level of care they're getting there regardless. And so of those roughly 90 people, I think on average, we talk about a number of 20 or 22 people at any given time that would not be optimal to transition them off the grounds there and into the community. So rather than engage the community with regards to a closure of Southbury, I've been engaging the Home and School Association, Disability Rights Connecticut, and other stakeholders in what a future use plan for the grounds and buildings would be. And in an ideal world, it would benefit both the Southbury community specifically. Perhaps some of those buildings have great utility for a town like Southbury, but also that there are other populations that may benefit from the beautiful land. Buildings would need to be remedied as they've been mothballed for a number of years. They're not move-in ready. There'd be some investment to use some of the retired buildings in a more modern way. But we are engaged in that conversation, and I think that is, to me, the better approach. Having been here now in the state for over 20 years and seen other state entities shutter a business but not have a plan for future use has left land and buildings fallow, seaside, things like that. And I think that we can do better as a state in terms of repurposing that than abandoning it.
So I couldn't agree more, because I think I've brought this up to you and others in the past. We closed Mansfield Training School and a number of other facilities. Some we repurposed into other things. We did the same thing with Norwich State Hospital in Fairfield Hills. When we did the Norwich State Hospital, which interestingly enough mostly resides in the town of Preston, not in the town of Norwich, kind of like the sub base, which we call the New London sub base, but it lives in Groton. So, you just have to know your area. And Groton is not Senator Marx's, but New London is. I know she tries to steal those constituents, but she cannot. But I really do think that we have to pay attention to what we're doing, and it is a site that has the availability of usage and the availability of resources that we could address. Now, it cost us as a state, several $1 million to do the cleanup at the Preston side of the Norwich State Hospital, and we're working on the Norwich side of the Norwich State Hospital now. But to just have these buildings remain, to go fallow and remain fallow and not either take them down or decide what we're going to do with them, I think is not good. And so I appreciate your looking at options for this and how we are going to handle the closure here. I'll have a couple of other questions. Does anybody else? Representative Nuccio.
Thank you, Madam Chair. I have a question regarding the distribute provider bonus funding. Was that an actual a one-time bonus that we're now continuing on, or were these increases in rates that we're annualizing?
So the funding was in 2 previous fiscal years, and the goal of that is to get it into rates. So right now we pay it as a separate payment, but we really want to get that funding in providers' rates so that they know exactly what they're getting paid when they are providing the services.
So it was in the 2 prior years and we're just annualizing it.
You're annualizing it and putting it into the community residential, employment and day services, and behavioral services accounts. So just moving the money to those accounts so we can integrate it properly into rates.
Okay. And then you just talked about that one. Kathy asked that one. Sorry. The provide funding for residential and day services. I was wondering if you could give a little more background on this, because the 2026 year, there's a reduction of 6.2 million. And then in the next year is an $8 million increase, which is it's like a $14 million swing here. So can you just, and same thing with like the community residential services, it's $4 million in one year, and then it's $14 million in the next year.
Yeah, so there's funding that is currently included in our baseline fiscal year 25 budget that would have likely moved out of that budget. Some examples of that funding include lower utilization since the pandemic, changes in the age of special education, and those things are adjustments that are being made to the DDS budget for money that we currently aren't using because of lower utilization or because people are leaving school at a greater age than was intended in the fiscal year 24 budget, which rolled into the fiscal year 25 budget. So there are offsets in this budget. So when you look at that funding, it's offset so that we're getting money for caseload growth, but they're taking back money for things that are not actually happening, that were planned to happen if pre-pandemic utilization was to return, or if the age of special education never changed. But because those things changed, there's an offset.
Can you break that down for us in the subcommittee? I'd like to see the moving pieces, like what was there with COVID, what's changed, like how that works. Because again, like that's a $14 million swing in one year. And I didn't think utilization was going up so high to indicate a $14 million increase year over year. So if we can just kind of get the breakdown of how that's flowing, I would really appreciate that.
Will do.
I think that's all that I have for you guys. Thank you.
Representative Dillon, followed by Representative Gilchrist.
Hello, Commissioner. Nice to
Good-
see you.
Good morning. Good to see you.
Good morning. This isn't what's in the document before us, but on the ground, a number of the private providers are struggling, especially, because of things that this committee didn't necessarily do. It might be the cost of energy to their facilities, but it's a lot of it is the funding that we provide and the wage changes we've made elsewhere. We had very emotional testimony before this committee last year at the end of the night from Marrakesh that they had to close one of their sites in Milford because they didn't have enough staff. And they were not competitive. And I had always thought siting would be the problem, so it took me by surprise. And I know it was late in the evening. I don't know if everyone saw it, but I guess I want to know because we own it if it's something we haven't done. Is there a problem on the ground with staffing that you see? And is it traceable to some budget action that we did or did not take?
We absolutely see an incredible shortage of direct care available to our providers in the job market. We see it here in Connecticut, and we see it nationally. We've taken steps, and I'll get back to your role and how you may assist in this, but we've taken steps to try and assist our provider community with that, including bringing on an employee whose sole job, she's a former private provider. Her sole job is to help us with workforce development. She does that in a number of ways. She does that on a national scale. We're part of a national learning collaborative that pairs us with 4 or 5 other states from around the country, learning what strategies they've used and how that has been effective. She does that in state with the Governor's Workforce Council, with the Department of Labor, and she does that with national trades types organizations, one in particular referred to as ANCOR. And so we have brought her in. In addition to that, we use some of the ARPA money to convey some of that money to providers to assist with recruitment and retention. And we reserved some of that money. We'll be releasing soon a video that helps promote the work, the great work that providers, direct care staff do, and let people know there's a need and that it's more than just a calling, that it's an actual job, that's a career, that's a profession, and some very targeted marketing to assist us with that. So we have done a number of things. The governor included in his proposal rate increase, a cost of living increase of 3% in each of the next 2 years, which will assist. What we do hear from providers is that higher wages will help, but we also hear that wages is not wages and competition come into play. So Secretary Barnes, I'll remember, instituted a minimum wage package for us a number of years ago. Secretary McCaw and later sort of grew on that, and we expanded that further. But at the same time, the effects of COVID drove up entry-level wages at retailers, and I don't wish to speak pejoratively about any of those jobs or denigrate any of those jobs. But we had sort of gotten ahead of some of the entry-level market, and we have fallen back in line with the entry-level market for employees. And so we intend to use the funding in the recommended budget from the governor to continue to allow providers to enhance that funding, but without targeting it specifically at wages. While appreciated the effort from the prior secretaries to do that, it didn't give providers flexibility to spend necessarily where they thought it would have the biggest impact. It directed them to distribute that funding across payroll and benefits and payroll-related benefits only, which was helpful. But as you suggested, other costs that have gone up, insurance, heat, and other things, they didn't have the discretion to manage that, and they didn't really have a lot of discretion in the number of our providers or in their own collective bargaining agreements. It took away some of the opportunity for them to do the work a private entity would typically do in those targeted wage increases. So we appreciate the recommended cost of living adjustment will allow providers more flexibility. So yes, money and wages is certainly a part of it, but what we've learned in our participation in this learning collaborative is letting people know that there's vertical growth and that there's horizontal movement, and that it isn't a dead end job, but it's really a career path you can follow, and then making that livable for them, making sure that there's a livable wage provided with that.
Madam Chair, with your, I just, and thank you. I think that's responsive, but the provider I singled out because of the testimony before us was founded in New Haven. It's now based in Woodbridge and has group homes all over the region, and lost one, secured a location in Milford and lost one. Do you have, for follow-up with us and with the Approps chairs, I guess, but certainly with the subcommittees, do you have a sense of parts of the state where the shortage of workers is more severe for your population than for others? Like, is there more of a problem in Eastern Connecticut or in Fairfield County, or there are variations?
I think that I think that there are variations. We used to focus heavily on the west coast of Connecticut, particularly in Lower Fairfield, because of the cost of living and the sharing of people across the New York border that happens there. That targeted, there were requests from terrific providers out that way that some targeted wages for them in their location were needed. They needed a different rate structure. What we've seen since the pandemic, since COVID, is that it's pretty universal. Whether it's our partners at the ARC Eastern CT down from New London all the way up to Putnam, whether it's right here in Hartford with Oak Hill and all of the other providers there, or Star and Marrakesh and Ability out in our western region, everyone is struggling. There has been some slowing from what anecdotally we have heard, that turnover seems to be decreasing a little bit. And the retention seems to be a little bit higher, but it remains a struggle statewide. While I appreciate the specific concerns of Lower Fairfield and the Connecticut-New York coastline or border, I think that providers are feeling it universally at present.
Thank you.
Up next is Representative Gilchrist, followed by Representative Kennedy.
Great. Thank you, Madam Chair. Good to see you, Commissioner and
Good to see
team.
you.
When it comes to the employment opportunities and day services line item and the community residential services line item, included in those line items, does that include both services that are provided by DDS and services provided by private providers?
The services in that grant account, that line item, are for private providers or for self-hire. So self-directed services money would also come out of that grant account. We refer to it as a grant account. We don't issue grants, but from that grant account. So day and employment service options would include all of our private providers. We have very, very little, if any, day supports left in the public. That would come out of our PS line.
Okay. And so community residential services, same thing?
That is all grants and or self-directed funding.
Okay.
That is all private provider or self-directed funding.
Okay, thank you. Want to go to the emergency placements. I see in the line item, first, could you explain what that is? And then I see that you all requested more than was given, and what was given from the governor appears to be less than what you already are receiving. Could you speak to what are emergency placements, why you asked for the larger increase, and what the impact would be on the lower than what is currently allocated?
Yeah, I'm going to do a little history while Nick does a little math.
Okay.
So that line item, as it's labeled, emergency placements, was an amount of money going back to the Malloy Barnes administration that was afforded to us as we thought was going to be one time to alleviate some of the strain for people struggling to get into placement from hospitals or from other places, and to try and there was some heightened pressure around getting a number of people placed quickly. So originally we used the money for that. It has remained with that name, even though we've used it a little more broadly since then to approach emergencies as opposed to just placements, to look for treatment and support to help stabilize people. So we have used that funding in a variety of ways since it came into our budget a number of years back, to include creation of step-down units, which gives us a place to stabilize someone and maybe not look at a lifelong group home placement, but maybe only a period of time in an intensive place. We've used it for emergency placements, and the specific ask this year, which I'm hoping Nick is now ready for. I think I have vamped long enough. He can tell you a little bit more about the current use of the funding and what the requests were and the impact it may have. I can come back to.
Yeah, the change in the funding is actually due to the centralization of IT. So there's a number of costs that we spend on IT expenditures in that account for the population Jordan mentioned. And as part of the centralization, we would move those costs from our budget into the DAS budget. And so that's the difference between the amount that we have this year versus the amount we would have next year.
Nick, if I can ask a follow-up on behalf of the representative.
Yeah.
Is there a certain amount of money that's come out of multiple lines, or was our DAS money moved to cover IT just from that emergency placement line?
The money comes out of multiple lines for IT, our salaries, PS, OE, ID partnership, and emergency placements. This is specifically, the question you ask is specifically the cost of IT for the people that we serve in emergency placements. So if you look at the policy revisions, there's about a $40,071 shift of money from DDS to DAS. And that's the difference between what our budget was this year and what our budget is being requested to be next year.
Okay, thank you. And then the follow-up, what was your request to increase it and what are you not getting based on that not being approved?
I'm not recalling a budget expansion option we submitted on that line, so I can follow up on that for you because it's not in my head at the moment, and we can follow up on that.
That'd be great. And for the work group, I know you said what's in there, but it would be great to have a breakdown of what's included in the emergency placement since the title's a little off.
You got it.
And then one more, if it's okay, just with the Southbury, when you talk about the future use, which is fantastic, you're doing that work. Is there a work group? Is there like meetings? Or is there some kind of plan and timeline that we could take a look at?
So the answer to the last part of your question is no, not yet.
Okay.
The answer to the first part is, as you all know, Southbury is a lightning rod conversation in the community, and it's very polarizing when we talk about it. It's taken me a number of years to get multiple parties sort of looking at it the way I've been looking at it, and I would say I've spent maybe in partnership with the with some of the players that I already mentioned, onboarding people to the notion that a closure may not be in anyone's best interest, even though we will someday not operate services the way we currently do on the grounds there. So that's been multiple years. Legislative session I had a couple of those meetings just before the holidays. Now we're in legislative session, but my chief of staff is working on bringing a table together that will include Disability Rights Connecticut, other groups in the state like Disability Rights who have an interest, the Family and Friends Home and School Association entity that exists for individuals out there, the remedial expert, and at some point we would like to expand that to include Southbury people outside of Southbury Training School, citizens of the town of Southbury who may have an interest, and so we planned on expanding that, but I will get you sort of a timeline for our first sort of bigger meeting. We haven't had a big table meeting yet. I've been meeting with each separately to bring them along on this vision, but we plan on bringing them together. And we just recently met with Disability Rights Connecticut in the governor's office to have this conversation, and I think that it went well. I think there are certainly people who, for lots of good reasons, would really just want to hear that we're closing it, but I think that I've been able to, over a number of years, explain why cutting off our nose to spite our face is probably not in anyone's best interest, least of all DDS's. So we're going to continue that work, and we'll let you know when we're meeting next and what that schedule will look like. There are a number of other state agencies that will come into the conversation as we advance this because, you know, DEEP will need to be involved. We have brooks and river and a pond and a dam. Ag is interested. We've given 2 parcels conveyed through the legislature, 2 parcels of farm, what we call the upper farms, on the grounds to ag that are under lease for and have an agricultural purpose. So as we move forward, that circle will expand. We've kept it small because I'm trying to focus it on something that has not historically been popular.
Thank you. I respect that. And I know so many of us have stories in West Hartford. We have the old UConn Hartford campus, and I Googled during this meeting, it was fall of 2017 when that moved, and we are still putting along to get that sold off. So yeah, I appreciate what you're doing, and if we can be of any assistance, again, recognizing the tensions that lie with that discussion, but having gone to visit it, a lot of buildings are closed, but have to, right, they still have to check them. And so is there a way to start to sell off or like you said, repurpose, and what would the cleanup look like and all that?
And some of our decision making was impacted by those historic floods. While we weren't on some of the news stories, I had a crew on the ground there of about 3 or 4 people who kept us functional, who kept potable water on the grounds during that flooding, who kept energy running. on the grounds who were assisting in a municipal aid fashion, some of the traffic that was impacted in front of the school. We have property on both sides of that road. My grounds and maintenance folks did a phenomenal job, and I appreciate that you've been to visit. I would encourage all of you who are interested, if you would like to see Southbury, to reach out to us through Kevin Bronson, my legislative liaison. We would be happy to tour you through there, both in and outside the buildings, and explain the grounds, how it's important not just to DBS but the community there in Southbury. And I think the more eyes we have on it, the better. My notion that there's a future for Southbury that looks very different than its history, but will be, there are very little places in the state you have that much green acreage on prime real estate right off of 84 in the 60 triangle that the governor mentioned during his first run. It's situated beautifully. I think it has a lot of potentiality.
Yeah, thank you. I appreciate the opportunity to have gone out there, and it was a lovely day in the fall. So thank you.
It's beautiful in the fall. Holy moly.
Representative Kennedy, followed by Senator Marks.
Thank you, Madam Chair, and welcome, Commissioners. Nice to see you. So your caseload growth, where are caseload? Where are you with that? I guess I'm looking for a waiting list. Or how many people are on a waiting list at this point, waiting to be served? Can you address that?
So with regards to the waiting list, I caution that the numbers with regards to the waiting list are just a slice in time on any given day. And I think that right now, our number is around 900 on the waiting list, which may seem high. At the same time that the wait list number has grown, we also successfully in the last fiscal year placed about 857 people. One of the things I cautioned last year, as the generosity from both the governor and the legislature has allowed me to continue to try and work through the wait list and with the ARPA funding, that when we do good work of placing people hear that we're doing good work placing people and get in line because they hear that there's something to have. For many years, we had nothing to offer unless you were an emergency. With our numbers last year were around 850 placements. The average over the last 10 years was around 450 placements. So it's not quite double. We've had some years up and some years down. Some years there's been a pandemic. Some years there's been some money offered us through you for waitlist activity to target families. So we have maintained at one point a number of years ago, we had a target on what we for waitlist around aging caregivers. We used the number of 70. We are now focusing on primary caregivers 65 and older, and sometimes even younger, for opportunities for placement without having to be an emergency. And we've offer now several other service types besides group homes that you don't have to wait for. If you're interested in a community companion home or certain aspects of our other services, they are readily available. The CCH's community companion homes take time to cultivate and pair match. And we have money for assistive technology. There's other things that people don't have to wait for. When we talk about that wait list, we're really talking about waiting for a 24-hour a day, 7-day a week setting. And while there are plenty of people who need that, we've been able to address the needs of many people, including some of those, but other people in that process. But the number now, I think, is around 900.
Thank you for that, Commissioner. I just want to remark on the facility in Orange that opened up, what is it, 2 years ago now?
I think it's is it 2
Is
years?
it 2 years already? Wow, it's remarkable.
That's our supportive housing?
Yes, it's
Is
remarkable.
that Ableist?
Was that, I'm sorry.
Is Ableist the provider there? I'm trying to remember who.
You know what, I should know that, but I
Okay.
don't, but it's on Smith Farm, but
Yeah.
it's great to see. I met a lot of the residents there from the IDD community, and just remarkable to see them flourish in their settings, so.
You'll likely hear from Steve Morris on supportive housing, and he's sort of our pioneer in the private provider world. I think he has 2 successful supportive housing developments already up and running. We have over 100 people living in those supportive housing opportunities. We have over 100 more of those units coming online. We've been able to go coast to coast. A new ARC Eastern CT now has them. We are still heavily Hartford centric, but we've made some penetration in the last couple of years into towns where affordable housing hasn't always been there for people with intellectual disability.
Yes.
And we have found that we are getting a warmer and warmer welcome as they see the one in Orange and some of the other places. And how wonderful they are. So we think that really remains a big part of our future.
Thank you, Commissioner. I look forward to hearing more about Southbury. Thank you, Madam Chair.
Thank you, Senator Marks.
Thank you, Madam Chair. Thank you, Commissioner. Good to see you in person and not on that Zoom. Um, So we hear so all the time, right, from the families that you serve. They're vocal. They are such advocates for their loved ones, and we hear from the providers as well. And not always good stories. Not always. There's 300 people signed up this evening. So if things were great, I don't think we'd have 300 people signed up this evening. It's going to be a long, sad night. So what are you hearing? And do you think the services that we provide are adequate?
So we are ever striving for improved quality and increasing the opportunities. We have worked hard to sort of broaden from what used to be the 2 or 3 buckets, group homes only, employment or non-employment day programs. We've tried to make a more open menu to allow for individual choice. I can tell you what I hear, some of the things I hear routinely, and I hear a lot, so I'll just focus on the brightest blips on my radar. Complex care for individuals with high level autism. And one of my friends in the room here has the right word for it, but they differentiate within the autism community is the type of autism and the level of need that we struggle both vocationally and residentially to provide immediate and adequate levels of support and treatment for those individuals. So similarly, co-occurring mental illness and IDD is a struggle area for us, and increasingly, and to Senator Austin's original comment about us doing such a good job with longevity, complex medical care. And you and I have certainly had conversations about complex medical care, finding the right balance of what we can allow through regulation and code, federal guidelines and state guidelines for the delegation of certain medical supports, limits who we can have living in certain types of programs and support structures. I think that those 3 areas, those 3 areas of things I hear about mostly from my families. I hear from providers, we can do more if we had more staffing. So those 3 things are incredibly important and on our radar. We have all sorts of activity trying to improve in those areas. All of it is stymied by the workforce crisis.
Do you lose sleep at night over the staffing? I mean, I do, right? It's the staffing is awful at times. And you said you went from 400 to 800 placements. Is that what you said? I mean,
We had like a 10-year average of around 450 placements from the wait list to around 850 in this last year. A lot of that has to do with our leveraging ARPA, which will go away. I'm not promising to have those numbers in years going forward. Just wanted to let you know how we did last year. We may fall back to average, we may not. But I lose sleep over the staffing. I lose sleep over a lot of things, Senator Marks, related to work and not related to work. There's plenty to lose sleep over. And I think I mentioned the things I'm aware of that are burning issues for us. I lose sleep over the things I'm not yet aware of. And what may be coming next. So if you want to play Scrabble or something online in the middle of the night, I'm up often. And
I'm a really good Scrabble player.
Oh, then I don't take another game.
And how much of our funding do we get from the federal government? I mean, I'm sure Medicaid, right? It's the Medicaid dollars, but is there other funding as well?
Unlike some of the other agencies that'll testify before you, we are almost all of our federal funding comes through the waiver. So I don't have, I have colleagues who work under the DDS umbrella in terms of how money flows through our partnership with the DD Council, our relationship with the DD Council. There's some funding stream that comes in that way, but for our services, for our supports, it's around 50 cents on the dollar, sometimes a little higher if we're using MFP. Gets us to around 75 cents on the dollar. There are some services that we provide, a very small amount of them, that don't get any federal revenue because they are supports and services that exist outside what is waiverable under the federal guidance. And so we state fund only those, but between the MFP and that, we average about 50 cents on the dollar.
Okay. Madam Chair, may I ask one more
Yep.
on the same subject? And then how do you evaluate the health of the agencies that are caring for our constituents that have this program?
So we have a pretty complex and comprehensive quality assurance system, both through licensing and through quality service reviews, two separate processes. And we have to report out, it's a requirement for us to report out on certain quality assurances to the federal government to ensure that we can maintain that funding and that FMAP going forward. It's a lot to get into. I'd be very happy to provide a summary for you in writing about both of those ways that we measure accountability and productivity and quality for our providers. But I'm not really well prepared to sort of
Yeah.
spin that off the top of my head at the moment. It's a big system with a lot of people involved, but on-site, and we also continuous quality improvement is important. Our providers do their own quality reviews as well, but we have oversight over all of that, and it's a big system.
Do you ever have a provider that doesn't meet the goals and that you have to get rid of them?
Yes, we have a stopgap measure between just getting rid of them. We certainly can in a couple of mechanisms doing so. We use a process called enhanced contract monitoring. When we see a provider that's struggling in a specific area or generally across multiple areas, in that we increase the amount of time on site and technical support that we provide providers. It used to be very much a gotcha system. We've tried to turn it into a partnership because we think it's more productive that way. And I think that providers have been more responsive to it. And some have even said they could use the extra hands on deck. When my regional directors choose to place a provider on enhanced contract monitoring, it increases the level of technical assistance, support, and oversight that a provider gets. And there's not a time limit on that. We've had some providers be on enhanced contract monitoring for 90 days and some for over a year, depending on the size of the issues, the size of the agency. And we are not interested in necessarily just getting rid of providers and only having a handful. We're very happy with the broad range of providers we have in our fold. So we're out there to support them and help them. There are some providers over the last number of years who have said goodbye to us, either of their own volition or of ours.
Thank you. That's interesting. And you don't have to send me anything. That was plenty to
Okay.
learn in 1 year. Perfect. I'll ask you something else next year. Thank you.
Thank you, Senator Marks.
Representative McCarthy Vahey, followed by Representative Gilchrist.
Thank you very much, Madam Chair. Commissioner, it's nice to see you and your team here from DDS. Thank you for being with us. I have two questions. One is, how are you seeing the impact of the cost of housing and the types of housing available on services? And I know you've talked a little bit about that, but I'm wondering if you can give us some specific examples of how and where you're seeing that impact.
When I came to the state 20 years ago, I could go through and develop a plan for a group home and acquire a house and get all that done in under a year. I could go from the initial concept to being ready and open in under a year. The housing market, because of some of the requirements, both internally and with our funding partners, sometimes it takes a year to identify a property that you can get under deposit because they move so quickly, and because the state rightfully wants to be careful about their investments when we give money to providers or entities to buy things. We want to make sure they're quality. So we require an appraisal. We require an inspection. A lot of the properties we are seeing are going for cash, sight unseen without inspection. All those things are being waived. It makes it incredibly hard for our providers who are not development corporations, right? They're human service providers who are out there trying to do this other book of business. So we have seen a much longer timeline. We do develop new homes and put out RFPs for new homes. Very often it's 18 months or longer from the offer of developing a home to getting it online. And a lot of that time is just chasing down a functional property. That is also within our cost standards. So we have granted some variance on those cost standards because the market is just not realistic for those cost standards for our providers. And we have worked closely with DSS to do that, but it is challenging. We have been very fortunate. Our partners at Department of Housing and Commissioner Salema Scarabruno and her staff have partnered with us to develop the supportive housing models that Representative Kennedy was talking about. I have lots of providers who would love to see you to come and visit them so you could see what those are all about if you haven't seen them. And I was just at a groundbreaking for one at the L in West Hartford. That's our most recent to be secured. Those come with housing subsidy in perpetuity. So it's less threatened and we don't have to own it. There's a development corporation, a business entity who's very interested in having very good tenants, and the people I support tend to make incredible tenants. And so we have a number of providers who would love to see us do more and more of that. I think it's more cost effective for the state. And as the governor reminds me, we can't build more land. And so one thing Connecticut isn't going to grow over the next number of years is land. So we need to take and make the most impact we can on the land footprint we have. These supportive housing models really allow us to get the most out of the square footage of land being secured in terms of the number of housing units. And they are lovely, lovely. All of them have turned out just fantastic.
Thank you. That is an extremely helpful answer. And one clarification to that before my next question is the funding that you're talking about from the Department of Housing. Are those RAP funds or other funds in
They are
addition?
RAP funds as well as housing rounds. I don't know how steep you are in that. We can give you a sort of a breakdown of about the dozen or so developments in the works or ongoing, and what type of housing subsidies we're using. And I don't know that off the top of my head, but we certainly bring that to you.
That would be great. I know there's a hopeful development in Fairfield with our housing authority, and there are potentially some RAP vouchers that are going to help sustain and serve clients. So I think it's a great partnership. The second question is just what you're hearing, what the main theme it is that you're hearing from your stakeholder community, from providers, from the service recipients, the clients, and also from families. Like just your point about both the emergency funding, and I remember those days when the wait list was so long and the things we were hearing from those older family members who are caring for their family members. And now you talk about the change in the wait list again. And both the wait list issue, but also just the general themes of what you're hearing.
Yeah. So there's a lot in that question because you mentioned a lot of stakeholder groups. As you know, I employ bless you. I employ a number of self-advocates, people who have intellectual disability who work for the state, who help me in engaging the community in helping us push forward. But they're also my eyes and ears on a number of issues. I was going to try and avoid this, but I want to make clear, my self-advocates are very concerned about the threats to Medicaid and federal funding. They are losing sleep over that. So for me, that's the most important thing, is that we are prepared and ready if what we are used to in terms of partnership with the federal government changes. And the governor's office has been gracious enough to offer a ton of time to talk about that with him and with his staff, how we may brace and be prepared if something adverse impacts our community that way. So that's number one. I ran down a list for Senator Marks that I think covers a number of other issues. Profound autism, thank you, Adrian. Profound autism co-occurring with intellectual disability, complex persistent mental health issues co-occurring, complex medical issues. Those things combined with the workforce crisis explain to me, in my head anyway, why our wait list, despite all the movement we had last year, is stubborn. We have capacity in our private provider system in terms of available homes, and not entire homes, but bedrooms here and there. But it's a struggle for them to take on new business when they can hardly be in a position to safely staff their other programs. Sometimes that gets better and sometimes that gets worse. And they continue to be tremendous partners, engaging with us in all sorts of ways to be creative, asking us to look for gray in spaces that have been black and white for years. But those to me are workforce crisis, what potentially could impact us at the federal level, given that 50 cents on the dollar comes from them. And then those three areas of sort of distinct populations. That is not to say that I still don't hear from people who would like to see their loved one placed, whether that loved one is 18, 28, 58, or 88. We still struggle to place everybody exactly when they want to be placed. And we do still have people who have to wait because we're not ready for them because there's other people who are priorities ahead. That was probably the loudest issue for my first 4 years. This workforce crisis and the complex needs, I think, is louder to me now because we've been able to penetrate that wait list and afford, as my friend Lois says to me, I afford people some hope. We've been able to give people some hope that they don't have to wait until they're dead for their loved one to get placed. And I think that has changed the level of noise you hear from that distinct population, both what you're hearing and what I'm hearing. It isn't perfect. It isn't fixed, but it's better. And there's hope. They know there's a time that comes, hopefully long before they pass, that we will be able to help them.
Again, thank you very much for that answer. And certainly this committee and many other committees have been looking at how we can help address and support the workforce issues, but some of those outside pressures certainly impact. And I also just want to acknowledge the sense of uncertainty and fear that people feel is real. We try not to live in the what if world, but we also try to be thoughtful in how we plan. But there also is that just emotional piece. And, we're here to try and help support everyone through that. So thank you for your answers. Thank you, Madam Chair.
Representative Gilchrist.
Thank you, Madam Chair. Thank you again. And I apologize if this already got discussed and I maybe zoned out, but I don't know if it was. So we have a write-up about residential and day services, and it's saying that the employment opportunities and day services are going to see a $6 million reduction in 26, but then go up to 8 million in 27. Do you know why that is? And what is the impact of that in that 1 year?
So we can dive deeper into the math on that in the working group,
Okay.
and Nick will be happy to lead us through that. The essence is that we had some ARPA funds that were afforded that were clear were going to be one-times. They were not going to be annualized into our budget, and we are now at the end of that cycle. And so those are not annualized going forward.
Okay.
That represents a decrease in what's within my appropriation. But it will not represent a decrease in the rates offered providers now. So that decrease in funding doesn't turn into a rate decrease, but it does shrink temporarily the total pool of money. We were not able to spend all of that money in part because of the workforce crisis. So it will not have a direct impact on our current level of services. What gets it bigger in the end, and I'll ask Nick to correct me if I'm wrong, he's very good at that, is that we're going to receive in the governor's recommended budget COLAs, and it was great to hear that was included in the governor's budget proposal of 3% in each of the next 2 years because of some of the spending cap and stuff that's way beyond my pay scale, all that fancy stuff. It'll be instituted as 3%, but on January 1. So it's a net increase on an annualized basis of 1.5% in each of the next 2 years. But in perpetuity, it's a 3% increase in those 2 years. And that's how it ebbs back up above the reduction to something bigger than the reduction. And I think I got that. Did I get that okay?
Yeah, the only thing I would add is the numbers you're citing also include caseload growth. So in fiscal year 27, there'll be additional caseload growth for new graduates. And then also there is some funding in the budget for annualization of a previous increase. And the way that funding comes through our budget is in fiscal year 26, it's a combination of money. There is money coming through the budget, but there's also some leftover ARPA money we're going to use to fund that. And then in fiscal year 27, there's no more ARPA money to fund it. So that's why you see an increase in 27.
Thank you. Yeah, any breakdown you can bring to the work group would be great. Thanks.
Thank you.
So I have a couple questions just to wrap us up. Representative Dillon had to leave. She had a couple questions. I'm sure she'll bring them to the work group. You said there were 900 people, give or take, on the wait list right now,
Yes.
give or take. And you can break that up by those who have caregivers older than 65, give or take?
Yes.
Okay, if you could bring that to the work group, that would be helpful.
Yep. Yeah.
You had a just funding to reflect current requirements in the budget of a decrease of $11 million. Is that your lapse that you're having each year? I'm just making sure that we're not seeing a decrease beyond the lapse.
Yeah, that's the lapse in our personal service account.
And you have been experiencing that lapse for a couple of years now?
Yeah, the lapse was larger than that, and it's been reducing, but I think $11 million is around the current funding for that lapse.
Thank you. And then dental, how are we doing with dental services? Because we know that you have a unique clientele related to dental services.
Thank you for that. I think last year when we visited, there was some concern about a shutdown of our Norwich clinic. That has been
Correct.
fully reopened. There was a dentist on site, and it's fully staffed. I think I've been pretty clear. I'm committed until the marketplace can afford the appropriate dental care for individuals we support. We're going to continue to operate both dental clinics and utilize our contracts with UConn and St. Francis to afford people appropriate dental care. And for those not quite understanding that, we run into all sorts of issues, both with anxiety, but also posturing, swallowing, any number of issues that make dental care, which is healthcare, it's general healthcare, make dental care really complicated for our individuals. And so we're going to continue to do that. And I'm not aware of anything in the budget that would reduce our capacity there or inhibit our ability to continue those functions.
I appreciate that because dental care is healthcare. And if someone has a problem with dental care, often they have problems medically beyond that. So just want to make sure that you were able to staff up the respective clinics. Certainly appreciate Norwich, but just broadly, we think that dental care needs to be something that people can count on. And getting an appointment was a little difficult during COVID and a little bit after that. So I'm happy to see that turnaround. Are there any other comments or questions? I see nothing online and nothing in person. Commissioner, thank you very much.
Thank you.
Appreciate it.
I'll see you this afternoon.
Yes. All right, so that finishes our morning. We will now take a recess for an hour, and we'll be back here at 1 o'clock. It's an hour and 7 minutes according to my computer. And we'll be able to address the issues. Thank you. I have no idea. I still think that we did this wrong. I think that we need to do tree rings. I think this is stupid. I probably can't change it for this year, but we really need to. No, they ended about 1. They ended about 1.
I don't want to respond now. So it's they are not the go, even for a conservative, traditional conservative Republicans in Congress, they will not be.
What is this 2024 World Population Review? That is
That-
in the actual article, it's a 2024 World Population Review, so they all 225,000 people. And it's spent as 5,694 each, and it was 1.28 million. Ninth highest in the nation.
That one I think.
See, I'm looking at those core, I wanna see the core, and then the second one was the Institute on Tax and Economic Policy. Said that illegal immigrants pays 400 million. I'd like to, is that sales tax? Because you know who else pays sales tax? Massachusetts pays it.
It was ran in a large because they are trying to figure out 65. So the other two.
I'd like, look at the article, it talks about these two specific organizations.
Here, let me just take a photo of that. So I
Yeah,
can
because
just.
they're different, they didn't mention fair, they mentioned those specific organizations.
I know, but it's good. What's your main thing this year on that?
Check out the. Oh, yeah, no, I want to understand it. I just want to understand it. Oh, yeah. Hey. Pardon me? Hello? I'm gonna be here tonight. No, but the thing is, it doesn't matter how much they talk, they ignore that. All right, I'll see you guys.
Good afternoon, everybody. We're going to call the meeting back from recess, and we're going to go right into our program. Dr. Gill, are you on?
Good afternoon. I'm Dr. Maura DeJoseph. I'm going to be standing in for Dr. Gill today. I'm the Deputy Chief Medical Examiner.
All righty. So, do you have any opening comments that you want to make, Dr. DeJoseph?
Just to add that I'm joined today by Dwayne Gordon, who's our fiscal manager and administrator as well. And we've shared our written testimony with all of you, and we're happy to take whatever questions the committee has.
Thank you. And are you guys all set because it says in recess online here?
Dwayne and I are all set, if that was the question. Yes, we're prepared.
Not you two. I have,
Okay.
We just have to make our technology is all set.
We're
We're sure you're all set. Okay, and can you just let somebody know that it says in recess? It should not say in recess any longer. It should say that, it shouldn't say anything. It should just say in process or whatever it should say. Because we don't want to be making a mistake relative to the long-term impact. So, Doctor, we are, you actually don't have a whole lot here. Are you having any staffing problems relative to the workload that you have? We know that the maintenance of effort component of the Office of the Chief Medical Examiner was a problem for a while. We were not meeting our goals. Can you let us know where you stand relative to your goals?
I apologize, our paging system.
That's all right.
Okay. That's a new one for us.
Okay, my apologies. So our staffing has been very stable of late, and we've had the great fortune of being able to have hired 3 new full-time medical examiners to round out our complement of the doctors necessary to complete all the autopsies and fall under the recommended thresholds put forth by NAME, the accrediting body for our agency.
Okay, and so you don't have a backlog of autopsies to do or anything that would negatively impact what is happening relative to law enforcement or other conditions that you may be responsible for?
When it comes to staffing, no, we have no issues there. It's usually more on the facility side of things where we have our struggles.
And what are those?
In terms of having sufficient number of autopsy tables to do the examinations, we only really have 5, 4 of which are in one room. And so we can really only accommodate a limited number of examinations on a given day. So that's one of the issues, really more facility based. And additionally, when it comes to storage of decedents, we don't have sufficient storage within our walls. So we do still maintain a refrigerated tractor trailer for the ability to store additional remains.
Now, how many people can you store?
We can store about 100 comfortably.
Okay, so that's a lot, I would say, but maybe I'm wrong about that. How many people do you need storage for?
I mean, unfortunately, this week, as an example, the last few days, we've had 20 autopsies that had to be performed on each of 3 or 4 days. So that alone is already almost 80 people in the building at any one time. And then we have the cases coming in for the next day. And we have families who are still working to make their arrangements and may need more time. So unfortunately, our census is usually around 110, 120.
And have you asked for some upgrades to tables and spacing?
So we are working with Bond Commission and DAS on new facility. So that's something that's been in the works really through research, some design, and then a lot of logistics. We're a little bit on pause right now while it's determined the best place for our project to be seated. But that is something we've been working with the state on for several years now.
Thank you. Representative Walker.
Thank you, and thank you for coming to talk to us today. So I noticed in your budget that you're contracting for security services, and it says that there's no designated funding for premise security services currently. Is that, so this is something that is new to your budget?
It's not new. We've had security services just about 2 years now, and we have been utilizing the assistance of OPM in providing a funding source for that over the last few years. And during this budget ask, we positioned it within our own budget. And so that's why it appears as a new service. However, it's been an existing service.
Okay, so you were utilizing your existing budget at the time, and this year's where you're adding on.
Yes.
And it's for $306,000, et cetera, et cetera. Is that approximately the amount that you need, or is that the amount that you're supplementing?
Probably both. It's 24/7 coverage, so it also includes holidays and things like that. So it's sort of based on contracted rates for security guards. Obviously, we know those rates are always subject to change, but generally it falls within the amount necessary to keep that service uninterrupted.
Okay. Okay. Is the facility that you're in, is this a new facility?
No. 1986, I believe.
And you didn't have security before then?
We did not.
So I could have gone in and just taken a body away without any problem?
Well, obviously, we have security measures in place, but we never had a security guard.
Ah, okay. I didn't mean to be flippant, but I mean.
No, it's okay. And I certainly don't want the public feeling concerned about it either. But yeah, we had security measures in place, but the guard has been a great enhancement and has certainly helped us utilize staff who may otherwise have covered the role of signing in a visitor. Now we can put those staff in the roles that they make the most effort doing, whether it be medical records or other laboratory roles. We had used a variety of different people to cover that visitor management, and now we have a dedicated person to do that.
Okay, and IT maintenance, is that a new expense also?
So we've done quite a few things when it comes to building on our case management system and some interfaces with other data management systems statewide, one of which is the electronic death registry system. And the other is a connection with the Department of Consumer Protection. And so through these interfaces, we're really using them to push out the data that we need to for death certificates. And when it comes to consumer protection, we're also alerting the prescription monitoring program that a patient's deceased. With these enhancements have come maintenance fees through our contract with our IT vendor for our case management system. So we're seeking the money to ensure that we can cover those maintenances.
Okay, all right. The electronic death registry system, how long have you had that?
I think it got on board just at the end of 2020.
Yep, that's what I thought, because you were having some difficulty with maintaining the registry for people for COVID. I remember that was when that was discussed. So I'm glad that we unfortunate circumstances have helped us in advancing our maintenance and management of the things that are necessary, because I know a lot of people were complaining about that. So thank you.
Yeah.
Well, thank you very much. Thank you, Madam Chair.
Thank you. Representative Nuccio.
Thank you, Madam Chair. I'd like to kind of go back to the contracted security. You said you have one person doing that now?
So we have a service to cover 24/7, 365. So we have 3 different guards, 3 different shifts. But it may be more than 3 individuals because the weekend coverage may be different.
And do you know how much you're spending in total? Because this 306,000 is an add to what you're currently spending, correct?
I'd probably have to see if Dwayne could answer that question about the granularity of the actual expenses on the security guard. And if it's not something we could answer for you now, we could certainly bring it to the work session too.
Okay, I'd like to understand like what we're actually spending. And that's one guard 24 hours every day of the week. This is going to be a really stupid question, but is that something that Capitol Police could do? No? I,
Absolutely not. They do this building and only
In
this
this building?
and-
I
and
wasn't
this
sure,
building, LOB and the State House, that's it.
oh, they don't do any of that, okay. All right, yeah, so if we can, figure out, I'd like to know how much we're spending in total for this,
Yeah.
and then that's all that I have, thank you.
Okay.
Thank you. And I'm still concerned about Representative Walker carrying out bodies. Really kind of worried about that. Don't understand it. And I'm going to go back to NCIS and watch how Ducky and everybody else handles.
I'll give you the reassurance. We won't let Senator Walker do that.
Thank you. I really appreciate that because I was wondering where in goodness is she going with with bodies now.
It's quite the visual.
I make her walk sometimes and we're building up our strength, but you know, the whole idea of carrying a body around it. Representative Dillon.
Good afternoon, and thank you. That's good news about your staffing. It's really good to hear that. I do have a couple of questions where I'm not sure I understood what was going on here. In the other expenses account, the actuals in 24 jumped. Well, they jumped in 25 from 24, and again in 26. And I was just wondering what was driving that change in the OE account.
In part, we have a new negotiated contract for toxicology testing. So some of that has resulted in incremental increase in the costs of tox. I'm trying to think of other things that would have impacted the OE.
The security services, the
Right.
contracted security services is really, I think, the bulk of it.
Yeah, I don't think there's too much more that we've seen many forced increases to our work on, especially since the volume of work has actually sort of normalized, which we also appreciate in addition to having the staffing.
Now, given that your staffing problems seem to be gone, would it be fair to say that you don't have an overtime problem now?
I wish that were the case, but unfortunately, we do require overtime when it comes to the removals of bodies from scenes and from hospitals, where we have forensic technicians on call who respond to that in the middle of the night. And it does seem that that method of on call does result in some cost savings to the agency as opposed to employing 2 or 3 staff members around the clock to do that. So it has been an operational standard within our office for a long time, but that certainly does result in overtime on an on-call basis. And then in addition, we do work the weekends and the holidays, and there's differential pay associated with that as well. So that is all sort of lumped into those unanticipated overtime type expenses.
Now, how much money are we talking? Do you know off the top of your head?
In terms of
overtime, you can bring
overtime, and yeah, we can give you a real solid breakdown based on holiday overtime and those on-call responses by forensic technicians. We can provide that to the working group.
No, that's really, really helpful. Thank you very much.
You're welcome.
Representative Gilchrist.
Thank you, Madam Chair. Thank you for being here. In looking at the testimony that was submitted by the Chief Medical Examiner, you did speak to the need for the new building, but in his testimony, he's saying that if we don't get the new facilities, you'll likely lose your national accreditation this fall. So, so that was someone saying that this isn't the first. Can you just share, is that a big deal? Yeah, I guess maybe it's not.
So we've had ongoing issues with accreditation due to the facility. In prior years, we had ongoing issues with accreditation due to staffing. And so the staffing issues are totally resolved, and we meet the standards expected of the National Association of Medical Examiners now for those. However, the association does have standards when it comes to facilities and having sufficient space for storage of decedents, for autopsy examinations, for other components of storage within a building, and we don't meet those standards. So our loss of accreditation would be based on those physical plant issues, which we don't have an ability to correct without a construction project.
Okay, but you did say that that work, those conversations are happening with regards to bonding?
Yes.
Okay, all right, thank you.
Mhm.
Thank you. Are there any other comments or questions? Seeing none, you're all set, ma'am. Thank you very much.
Thank you. We'll see you in a few weeks.
Okay, do you know how, Dr. Gifford is coming on? Is she?
Coming on remotely? Not online, but.
Well, we've got 13 minutes, so we have time anyway. So if you want to just recess until she gets here. Okay? Once they get here, we'll start up again, but we'll wait to see that. So we'll recess until then. Dr. Gifford, you might as well come on up and start getting ready. Um, good afternoon. Uh, um, we're back off of recess, you two. And do you need to say a few words to start us in the right direction?
Thank you, Senator Deidre Gifford from the Office of Health Strategy. Glad to be with you this afternoon to talk about the Office of Health Strategy budget. I'll just introduce my terrific team, Kim Martone, who oversees our finance area, Boyd Jackson and Cindy Dubuque Gallo from our Ledge team, and Sumit Sachnani, the Health Information Technology Officer, who's here to answer any of your questions about our HIT budget. With that, happy to be here and respond to your questions.
Thank you. We had a task force this summer on the insurance fund. And your insurance fund numbers this time go up about $2 million or maybe $1.5 million from where you were in 25. So if I go to 25, it's 13.7, and in governor recommended it's 15.1. And I'd like you to bring to the group some way for us to move some of this back to the general fund, because we want to stop using the insurance fund to support outside agencies. We think that the insurance fund has a direct impact on insurance policies. And we really need to start going back to putting increases in the general fund, which from my perspective, as someone who not just in healthcare policies, but in policies relative to motor vehicles, policies relative to home insurance are all going up. And I'm not saying it's totally as a result of charges on the insurance fund, but that is a piece of the puzzle relative to this. So when you come to the work group, I'd like to look at some ideas that you have relative to moving some stuff back to the insurance fund. So for example, you have provide funding for a deputy commissioner. And personnel services, by and large, should be in the general fund. I think that makes a lot more sense. So that's a piece of the puzzle. I'd like to get that back down to, at a minimum, the dollar amount it was in 25. That's about $1.5 million is what I'm looking for to get back to the general fund. And I'd like to work with you on that to get where we need to be. That's also true on the Senior Director for Health Equity and Social Determinants. That may be another position that we can move over to the general fund. If these are positions you think are necessary, I'd rather pay for them out of the general fund and not out of the insurance fund. And looking at the gross fund federal share of health information exchange costs, if you could go over what that means so that I understand what it means.
Happy to, and I'll ask Sumit to join me if you need further detail. The approximately $1.1 million I think you see reflected, Senator, in the budget is a budgeting change that actually that full amount will come back to the state in federal match. So it's a change in the way it's reflected in our budget. It's not a change in the amount. And there were, for accounting purposes, because that money had previously gone to a different agency and was reimbursed through a different mechanism. The decision, I think, was that it made more sense to budget it in this way, but just to be clear to the whole committee, that amount does not reflect any increase, and that full amount will come back in federal funds.
So if it came back in federal funds, does it matter whether it's in the insurance fund or the general fund?
Well, it's for health information technology, which to date has been in the insurance fund.
Only because in 2017, we moved a lot of things off the general fund because we couldn't afford it. So we moved a lot of things and then expanded on that in the subsequent years. So I think that that's something that we may want to look at. These are three things that bring us down to below what we were, and starts changing the policy of using the insurance fund, which is directly reflective of charges on people's insurance policies broadly. Okay. Are there any other questions? Representative Nuccio.
Thank you, Madam Chair. In regards to what we were just talking about there, the health information exchange cost. So we see the expense here in the insurance fund, but I don't see the credit. So where does the credit go? If it's, because I don't think it shows up in the insurance fund anymore.
Do you know the answer?
It does get deposited back to the insurance fund. So there is a line item in the proposed budget for the governor, and that has a revenue line item in it. So we are getting the money in as part of that budget, and as soon as the federal claiming happens, it will get credited back to the insurance fund, making it a net zero impact to the insurance fund.
So it's on the revenue side.
Yes, there is a line item on the revenue side.
Okay, and do you know which agency this was in before?
So the reclaiming happens through Department of Social Services, and previously, I think the funding was partly coming to OHS, partly getting deposited in the general fund. We have now this year fixed that in the proposed budget, so it goes back to the insurance fund, which is where the HIE is funded for the state share of the fund. So HIE is funded two ways. It's funded federally and it's funded through a state match, and the state match comes through the insurance fund. So it's not 100% funded by state funding.
But the state match is coming through. Is that then being zeroed out, or are we just getting the federal piece back?
The federal piece is coming back to the insurance fund. So the federal reimbursement and reclaiming that we're doing is coming back to the insurance fund.
So does it end up being a net zero?
For the increase that we've asked
For the total line item?
No, there is a cost to the insurance fund for the HIE, but you see that there is about $1 million that we've asked for, which really is specifically related to the federal reclaiming and the deposit back to the insurance fund, making that increase as a zero offset.
Okay, can you then give us the total actual cost? Like when this, you can bring it to the work group, but the total actual cost less the revenue, so we can see what the net dollar amount that's in other for that, the health information exchange.
Sure thing.
Thank you. And then in regard to the sustained senior director for health equity and social determinants of health position, this says it's sustaining it, but it's a new add to yours. So do you know where it was before and how are we sustaining it?
So the position exists currently. It was funded through our current biennial budget. In addition to that, there was some grant funding to do the state health improvement plan that was through an agreement with DPH that funded a good chunk of that position. And those funds are terminating.
So it's actually a head that's in your budget. This is just the grant portion piece of that position?
It's not the full amount, correct?
Okay, All right, hold on, I'm just trying to wrap my head around this. So it's currently in the insurance fund. The head count is currently there.
I don't know for sure, Rep. Nuccio, so let me check where that position, whether it's insurance fund, general fund. I couldn't tell you off the top of my head.
Okay, because yeah, it's adding to the insurance fund. So I'd like to understand where this head currently lives, what the funding sources are for it, and then what the piece is that we're bringing over into the insurance fund, if possible.
Yeah.
And I think that's it for me. Thank you.
Anybody else have any questions? Senator Marks, followed by Representative Gilchrist. I'm sorry, Representative.
Hi.
Got to look at my sheet.
It's nice to see you. So Connie, I still don't really understand Connie. I know Rep. McCarthy Vey, he said I should meet with you, and I will do that after session. But we're spending a lot of money on it. Is it still necessary with the other exchanges that are out there?
So Sumit chairs the board of Connie, and so he can elaborate. I would point, Senator, to the slide that was in the testimony that we sent over. It says Connecticut Health Information Exchange, which gives you a very brief overview of what Connie has accomplished recently. So we're up to 3,000 plus connected organizations now in Connie. About 2.3 million patient alerts that are being sent out monthly. 1.5 million of weekly clinical data summaries that are being shared. So in answer to your question, and I understand why you're asking, because there are systems that share data within themselves, many of them large. What Connie does and why you all put it into statute and funded it was allow communication within and importantly outside those self-contained systems. Many people receive care through multiple systems. Not everyone receives care in a self-contained healthcare system, as you know. And so Connie really provides the unique capacity to exchange data and achieve all of the efficiencies and quality improvements that come with better data availability, both within and outside of a healthcare system. And that's why, even though there were these existing systems, the legislature, we assume, put it into statute because we needed that additional capacity.
Mostly professional.
Yes,
Well,
definitely
they
still
do
has
some
value. Okay, thank you for that. And there were just some questions asked yesterday, and one of them was whether or not there is an organizational chart for the agency.
Yes, there is.
Good.
Be happy to share that.
Yeah, awesome. And one more is how much of does the Office of Health Strategy spend on outside consulting?
We'll sum that up, Senator, and get that to you for the working groups.
Thank you. Appreciate that.
You're welcome.
Representative Gilchrist, then Representative Dillon. Representative Gilchrist.
Thank you, Madam Chair. Good to see you. Thank you for being here.
Thank you.
Recognizing this is the Money Committee and there are accompanying bills that went to public health and insurance, could you just give a brief overview of what the notice of material change, what those 3 positions look like, and then the same thing for the out-of-network hospital price limits, what those 5 positions would be doing?
Happy to. I'll invite Boyd Jackson to join me as well. So notice material change, as you know, is a proposal that the governor has put forth, which would establish a joint process between the Office of the Attorney General and the Office of Health Strategy to review certain types of significant healthcare transactions that currently don't receive any review. We also don't currently have an established pathway by which the OAG and OHS can collaborate. often in fact were prevented from doing so by the respective agencies' particular regimes for privacy. So this new bill would have the OAG receive these notices under defined significant transactions. They would review and could consult with us on those transactions. So there's one element that these positions would be used for would be assisting the OAG in their reviews, because we have the technical expertise, they have the legal and oversight expertise. And then if jointly the OAG and OHS thought that conditions should be imposed on those transactions, we would work jointly with them to develop those conditions, put them into a form of some kind of an agreement, and then assist the Office of the Attorney General in monitoring to make sure there was compliance with those conditions. You're welcome. Out-of-network caps, as you know, would limit what could be charged by a healthcare provider who was not in network for a particular patient. Right now, we know that those charges can be 7.5 times or more what Medicare would charge. So this proposal would put a cap on what could be charged to a reasonable amount, which is what providers are generally paid in the market now. The positions, the responsibility for monitoring and reporting on all of that work would fall to the Office of Health Strategy. So the positions are added to our budget for receiving information about charges that exceeded the out-of-network cap, producing an annual report on the out-of-network capping. What are some of the other functions?
Another portion is ensuring that all of the savings from the out-of-network caps are reflected in lower insurance premiums at the time of the rate hearing. So we our positions would be involved in ensuring that reporting took place and was accurately reflected in the insurance rate filings.
Thank you. Thank you very much.
Thank you, Representative.
All set?
Yes.
Representative Dillon.
Good afternoon. It's good to see you.
Thank you.
And I may be asking something someone asked ahead of time. There are some changes in your agency budget, and so it drew everyone's curiosity. Did you have a justification for creating a new position for a deputy commissioner?
Like most agencies, we think that OHS should have a deputy. It's a agency that has a broad range of responsibilities reflected in some of the things that we've just been talking about now, everything from health IT to data and measure and reporting to healthcare benchmarking, social determinants of health. And in fact, our statute includes creating a coordinated healthcare cost containment strategy for the state. So it is, although it's a small agency with a relatively small budget, it is a very broad set of responsibilities. So it's difficult for a single commissioner to oversee and be involved in all those activities. And so a deputy commissioner who can both support the role of the commissioner and take the place of the commissioner when she or he is unavailable would be important for the agency.
Thank you. And I think that if I recall correctly, some of it came in discussions among subcommittee members and some offline in terms of the confusion of people who maybe came here at different times or have different experiences about exactly how the relationship between yourself and the Attorney General's office would be as regards the health entity, the private equity piece. And I don't think it would be fair for me to characterize what all the questions were, but it seemed like it expressed itself in what's their organizational chart, what exactly do they do, who's in charge, sort of thing. And I don't know if we can really do justice to it today, you might want to do a separate little discussion when we get to work group. And that might be fair to everyone. But I think it generally came from people on Approps.
Happy to do that. And we recognize it is a newer agency. It's only been in existence since 2018. So there isn't the long decades of history of the agency and its functions. And in addition to being a new agency, new responsibilities and programs have been added year after year since 2019. So I think it's understandable that people want a clearer picture, and we're happy to do that.
I think that would be helpful and it'd be better. And I don't know if today would be fair to the rest of the committee, but thank you.
All set? Representative Kennedy.
Thank you, Madam Chair. And I'm sorry, I don't wish to belabor this, but just want to clarify a couple of things. Currently, you have how many employees in your office? 30.
Stand by.
Thank you. 30.
45.
Okay, and all those positions filled currently?
No, we have some vacancies.
Do you know how many vacancies at this point?
Well, you would think that would be an easy answer, Representative, but let me walk through. We have 5 positions that were funded in the current biennium. We did not fill all of those positions because part of that was related to a policy that was not enacted. We did fill some, 2, so that left us with a net minus of 3. And then we had some additional added. So we're at 4 vacancies when you do the pluses and minuses.
Okay. And then just for clarification further on the Senior Director for Health Equity. So that position came to you, but it was from the SDOH, previously managed by DPH. Now it's integrated into yours, OHS. But now it's going to, is the Attorney General's office going to oversee it or not? Or how is that, where is the physical person going to be, or where's the position going to physically be?
So the position was newly created at OHS. The position was funded in part by some grant funds that DPH had. And because the work that this role was doing aligned with that grant, the position was funded through that DPH grant. The Office of the Attorney General is not involved in this particular position.
And do you foresee that position being full-time or part-time?
Full-time.
Full-time? Could it be a part-time position?
No.
No. Okay. Thank you. I think that's it for now. Thank you, Madam Chair.
Representative Nuccio.
Thank you. Sorry, I've missed one of my questions. Along with the detail of the outside consulting total that you have, can you also break down the total of your other expenses? It looks like it's almost $12 million that we have in other, and I'd just kind of like to understand what falls underneath that and how much it is. And I think I now have all my questions.
Happy to do that. The majority, the health information technology sits in other expenses, so the majority of that is the HIT funding, but we'll be happy to break out the rest of the detail. And just so we're clear on the outside consulting, are you looking for our contracts with outside entities? So for example, our all payer claims database contract, or are you looking specifically for consultants?
I think it was in total. Yeah, I think, it's all of it. What are you paying an outside consulting? And to whom? For what?
Okay. Happy to do that.
All set? So I'm going to ask a couple questions about the specific hospitals. And so I'm going to start with the Connecticut Children's Medical Center. So we have all been meeting with all the hospitals that treat our respective constituents. Children's Medical Center treats somebody from each one of our districts, ends up there because of their specific related issue to children. And so I've been talking to them, and it seems to me that there is a process which is happening when you are doing a calculation of how profitable a hospital is. There seems to be some disconnect with this particular facility that's related to their expenses being paid for out of the foundation, which is not into the revenue stream. So there's two buckets here, two silos. And I want to make sure that we're understanding that what's happening at the Children's Medical, and we've been dealing with the Children's Medical Center broadly on appropriations for the whole time I've been on appropriations and much longer than that. Do you account for, when you're looking at the profitability, the two different buckets that Children's Medical Center has?
Thank you, Senator. We went over this at the office this week, and the report that you're referring to is our annual report on the financial stability of hospitals. It's just released, as you know, a few weeks ago. And we report, just to clarify, when you say a calculation, most of that report is reflective of data that the hospitals themselves submit on standardized forms to the Office of Health Strategy. They are reflective either of the hospital's audited financial statements or their Medicare cost reports or some other standard source of data. So the office is reflecting information that's provided to us by the hospitals. In the case of Connecticut Children's, they would like the revenue, the net assets of their foundation not to be included in their hospital revenue.
Right.
That's the question that they've asked. And we've met with them and their CFO multiple times at OHS. The reason why we report it the way we do is because that's how we report it for all the other hospitals that we could find that reported net income from a foundation. It's included in the hospital's revenue. They also have questions about how we report their losses from their affiliated provider groups. Again, I asked my team specifically, please go back and make sure we're treating CCMC exactly the same as we treat all the other hospitals and health systems in the state. And the team confirmed that the way we are reflecting their financials in the report is the same way that we reflect foundation net assets and physician group gains or losses for all other hospitals. And the result is that CCMC has both the highest profit margin in the most recently reported year and the highest profit margin over a 5-year period based on those calculations.
So I think that you're actually missing the boat on this one, quite frankly. Because the Children's Medical Center, so let's just take, for example, someone has to have a test done where you go in and you have to make sure that when you're doing the test that there is no movement of the particular patient. But you can't do that with children. So a lot of times you have to bring in for a treatment, you have to bring in another specialist for that treatment. And I'm not certain that the Children's Medical Center exactly correlates to our other hospitals under any circumstances. And I've been there multiple times and I've asked the questions, and I'm not somebody that likes to see somebody make profit above and beyond, but the things that they do there are so much different than what other hospitals do. Even their staffing ratios are different. They're relative to how we're accounting for and how you described looking at the revenue and expenses is not how I have seen their revenue and expenses accounted for. So I'd like to really delve down deeply into the Children's Medical Center because, quite frankly, that's not what I see. Because a lot of their expenses are paid for out of their foundation, and I don't see your calculation there, and a lot of the services they have additional expenses related to an issue that a child may have because they're children and we can't treat them the same. They have to have more medical attention during the treatment of whatever it may happen to be. So you can't tell a child that's having an x-ray, don't move, right? Just some may listen, but you're not getting a 2-year-old to stop moving about, right? You're not going to get a baby to stop moving about, but you may get an 8-year-old. They may listen. They're probably going to listen better than a 16-year-old. That would be absolutely true. But I really think that we need to pay attention to Children's Medical Center. And I'm wondering if you could have your group work on a calculation between Children's Medical Center and the other children's medical centers around the country, instead of trying to fit them into a square peg into a round hole and say you are just like every other hospital, when they're not like every other hospital. And you know, a lot of people will provide for their foundation resources that are restricted to specific things. And so it's the same thing when people are saying a foundation for, I'll just use Norwich Free Academy, the place that is a high school in my town, and most of their foundation are restricted assets for very specific grants and scholarships. That doesn't mean that they can use those funds for just whatever they want to use them for. So I think that, and a lot of people are willing to give money to a children's center that are not willing to necessarily give to other types of hospitals. And so I really would like you to go back, look at that, bring to the work group some explanations, because I am not seeing the consideration of the calculations that this hospital system has, and I don't see it as the same thing as going to Bacchus Hospital. You know, when I broke my leg, I went to Bacchus Hospital. They kicked me out at the end of the day. They were very good. I was glad they kicked me out, because if they hadn't, I would have walked out. I couldn't walk then, but I would have found a way out. But I just think that we're looking at an apples and oranges look at this, and I'd like you to go back and look at that a little bit differently. So we are going to be dealing with hospital issues, and a lot of people have said today, don't consider what the federal government is going to do until the federal government does it. And I'm putting a budget together with all of my colleagues that is really much going very much on where we stand today. And we're looking at that. We're paying attention to the talk up here, but we're basing it on what's going on today. But the hospital provider tax has been talked about at the Wall Street Journal, the New York Times, the NPR, any of the top media that really looks at things from different perspectives. And they have all said the same thing. The new administration broadly, not just one person, but broadly, has said that they don't like the hospital provider tax. They think it's their words, not mine, that it's a scam. And so I would like to know, and I know you're involved in the discussions on the hospital provider tax. I would really like to know what would be the implication should that get reversed by the federal government of us being able to use the hospital provider tax? What is the implication to our budget?
Senator, as you noted, it's been very hard to interpret what's happening right now at CMS and in Congress. And I think the provider tax is one of a very long list of of things that have been in the ether that would have profoundly negative consequences on state budgets. But to your point, none of them are a reality at the moment. With respect to the provider tax, it has been a long-standing practice of CMS, decades and decades old. It's used in virtually every state. Some states rely extremely heavily on the provider tax to fund the majority of their Medicaid program. And so I think although there have been threats to talk about, to change the basis of the provider tax, I think when the reality of altering a system that both federal and state governments have been using over decades to support this program, I think that there will be some more sober thoughts about whether that's something that should be changed. And it's generally supported both by states and by providers, because it's used, although it's a tax, it's also used as a way to support rates and supplemental payments for providers. And so generally providers have, as a matter of principle, there are debates about, the type and the amount, but as a matter of principle, both providers and state governments have generally, and the federal government, have been in support of this mechanism.
So this is the one thing that I'd like to really understand a lot more, because it does have a large impact on our budget. And we are going to be asked to even vote in special session on hospital-related issues like the CON, and what's going to happen with Prospect and a number of other things. And so I think that I don't want to wait to say what's going to happen if. I would like to understand the hospital provider tax. I've asked to meet with the hospitals on the hospital provider tax. I will meet with them. I'm giving you the same opportunity to meet on the hospital provider tax, because to me, it's not something, if I'm going to have to delve into this, like I got pulled kicking and screaming into the insurance fund discussion, I need to understand it more from your perspective and from their perspective, so that should something happen, and I'm not borrowing trouble, I am reacting to what is being said and out loud by the this new administration broadly, not just one person. I'm not blaming any one person. I don't really care. It is a policy that's being talked about, a policy change. And I would like to understand that policy change from your perspective on what that would mean. I tend to ignore some of anybody that thinks that I'm going to listen to a policy on Twitter or X or whatever social media source that we're talking about now. I don't even know them all. I'm going to have a great grandchild this year. I'm going to count on them, because I'm certain that when they're born, they're going to know more about social media than I am. And I just think that this is something that we can't just not understand more. And many of my colleagues have said, we need to understand this. What are the implications? How does this work? You can say it's in every other state. Bring us a list so that we have every other state that's counting on this and what it's doing. So, and I appreciate your answers. Are there any other questions from anybody? Representative Nuccio.
I'd just like to tack on to what Kathy is saying there. I'm one of those people who have been throwing her articles because this is an item of concern for me, because the governor is also blowing it out and using that as a revenue generator going forward with the comptroller. And I'm the person that's usually up here just saying, okay, let's just see what actually happens. I don't take people by what they say. I take people by their actions. But this has been very widely spoken about by multiple different people. And I won't be as nice as Kathy. The words that are going around is it's a money laundering scheme. That's how the federal government is looking at this, because they know that it's intentionally done to pull down more Medicaid dollars. So this is an area that I too would like to understand the ins and outs of it, even from just a current perspective. What are we currently doing? how does that flow and work? Before we even look at the governor's assumption of expanding it. I think, there are certain things that may be more likely than not that are going to happen with this administration. One of them I keep saying is that we have to look at the Medicaid rates, and we have to look at a 5%, a 10%, a 15%, a 30% cut, and what that means. This hospital tax is my other one. This one here is one that I think we fully need to understand how it's in here, how it's baked in, and how we unravel it. Even if you're just unraveling it by, maybe they say, okay, we're going to do it, but we're only going to match it 20%. Right? Like, so we need to understand it well enough to be able to play with the levers to say, this is what the impact is going to be. And I don't think that's the sky is falling. I think that is just reacting to what multiple people in the federal government right now are saying, and multiple sources are all pointing to. So I think that, and in regards to the children's, I'm not as up to date as Kathy is on that, but perhaps there's a way to look at the differences in services provided and weight that differently for an all children's hospital than a regular hospital from the perspective of their reporting. I'll try to educate myself more on that before we get more information, but that might be something I think would be worthy to try to think about.
Thank you.
Representative Dillon.
Madam Chair, could I just respond? to
Yes,
Representative?
yeah, I'm sorry.
That's okay. I just wanted to be clear with respect to the provider tax. Add something to my response, which is I know that DSS and OPM and the governor's office have, as you're pointing out, have been following a lot of the proposals, particularly related to Medicaid, and have been looking at the potential impact of those various policies. There's also a lot of outside kind of think tank organizations who've been helping states model what the implications might be. So I didn't mean to imply that the relevant state agencies weren't looking at it. So whether it's at our follow-up or at DSS's or in another conversation, of course, we'd be happy to talk about it further.
Representative Dillon.
Thank you, Madam Chair. And in the same vein, and I'm not going to pretend to understand the state of things right now because they seem to change a lot. If I recall, we had a fairly thick settlement with the Hospital Association, which included a restriction on hospital-specific taxes. And I could be wrong about that, but if you're going to prepare a presentation to us so that we have a plan, and given that I'm seeing a lot of things that concern me, and I just don't know what they're going to do down there or who's going to drive it. But whether or not that could include a recognition that we do have a settlement, which I think binds the state and may restrict our action. I'm not sure about that. And I do have my big binder still home laying that out, but that might be something that we could at least take into consideration when we're looking at provider taxes.
Representative, that of course the Department of Social Services oversees the provider tax because it's administered through the Medicaid program. But to your point, the agreement with the hospitals does expire at the end of fiscal 26. So whatever agreement the state had with the hospitals with respect to the tax and the supplemental payments, that existing agreement ends in fiscal 26.
Oh boy, thank you.
Yes. Yeah. Everybody else set? We're going to let you go.
We miss you,
We think-
Representative Walker. I'm not asking for questions, though. I just wanted to acknowledge you.
I already asked her if she had any.
I started and then I said no, because
We got
tired.
All right. Thank you very much. Commissioner Navarrete, I think you're up next. Right, that's what we're.
That's what we're doing.
Well, except that the governor is pumping it up.
Yeah.
That's what he's trying to do. That's-
Good afternoon, everybody. Good afternoon,
afternoon.
Commissioner. Oh, this is a long week. It's only 4 days too. Thank
No
you,
surprises, please.
thank you for coming for testimony. Do you want to give us some brief moments, brief comments, and then we go into questioning?
Sure. Good afternoon. I'm Nancy Navarrete. I'm the Commissioner of the Department of Mental Health and Addiction Services. And I have with me Cheryl Aurora. She is the CFO of the department. You have our written testimony, and so we are before you to answer any questions that you may have.
Okay, great. Questions? No, I just sat down.
She's sending it over to me first.
First, yeah.
Wow.
Okay.
Yeah, so I definitely in reviewing this, I have some questions. The first question I had is in relation to the state funded prevention activities. I noticed we're cutting 7 heads here, 1.7 million. I was wondering if you could give us a little more detail about that.
Sure. So just for context, we are statutorily required to cover prevention for the state of Connecticut across the lifespan. So children and adults, unlike the mental health system or the substance use system. And we cover wellness, mental health, prevention of substance use, substance misuse. We cover suicide prevention and intervention. Those are some of the activities within this department. So this is a cut of 7 positions, which is 58% of our staff and 45% of our state budget. So it has potential implications in a variety of different areas, and we would work with our state partners and our prevention network to try and cover those gaps.
So we're just cutting positions to meet the budget, basically.
Pardon me?
We're just cutting positions to meet the budget number, like there's nothing that's saying we don't need this work?
Well, this was a cut that was proposed, yes, to create efficiencies.
Okay, let's get to the next efficiency. Where are we currently on overtime this year?
So we're doing better in the past 2 years. Our highest overtime year was 2023 as we were coming out of the pandemic. And that number is coming down, and we can certainly show you historic run of what the numbers are for mandated overtime, time and a half. Our greatest reduction has been in mandated overtime. That's always the area that's of most concern because it is double time, and that has come down significantly. So we'll continue to work on that. One of the proposals in here is to implement Kronos, and Kronos is hardware and software. So actually before COVID, we had the time clocks installed in all of our buildings, and they are still there. What happened was the process got slowed down when everyone had to leave for COVID. And so now we're ready to get back to implement that. There are other state departments that already use Kronos, DVA, DCF, DESP uses it. So it's something that people have found effective for both scheduling and for swiping in and swiping out.
Okay, can you just very quickly, I should have asked you, how many vacancies do you currently have?
161.
161. Okay, and has that gone, like, I'm just trying to figure out how we're just cutting overtime, right? Because DMHAS is like, you guys have a lot of stuff. So we have $1 million cut in year 1 and a $3 million cut in year 2. You're saying you think you can achieve this?
Yes.
Okay, all right, then that's good to know. The reduction for staff through attrition, the additional 5 heads there, is this, it says decreased staffing needs in the commissioner's office. Is this something you're comfortable with?
It's a 1.3% decrease, so it's a small decrease that we think we can absorb over time with attrition.
Okay. And then, let's see, you have, I think this is why I'm confused, right? Because you currently have, you're annualizing $9 million of deficiencies.
Mhm.
So what is your projected deficiency for this year? Our camera's doing really
Yeah,
weird thing right now.
Zeroed in on your water bottle.
Did, yeah. It's
So
not
those deficiencies were in a couple of different areas. So it was OE,
Mhm.
professional services, behavioral health medications, and discharge and diversion funds. So as we all know, costs have increased. We run very large hospitals. And so things like food services and electricity have gone up, and this makes us whole for those kinds of costs that just skyrocketed.
Okay, what is your lapse in PS then? Because these aren't PS, these are
For-
other
For
professional.
for which year?
This year, what are you projecting your lapse to be? Do you have a lapse this year? You don't have a lapse.
No.
We have.
Could you introduce yourself, please? Excuse me, could you introduce yourself, please?
My name is Cheryl Lavora. I'm the CFO for DMHAS.
I can't hear you, babe. You got to move the microphone. Thank you. There you go.
Cheryl Lavora, CFO for DMHAS. I believe it's 15.6 million that's recognized as a deficiency in personal services.
So that's a deficiency or a lapse? Like you have that left or you're over?
It's a deficiency.
Because that's not on here, right? If we're looking at like annualizing the deficiencies, I don't see a $15.6 million deficiency in PS.
It's annualizing what happened last year.
What is it this year? This
So
current
the
year, what are you
projection
projecting
would
for
be-
this year?
Our projected deficiency this year is the 15.6 million in personal services.
Neil? Do you happen to know why that wouldn't be showing up?
It's not.
No? Oh. Okay.
Okay.
All right, okay, so you have a $15.6 million deficiency in PS. We are then cutting $700,000 out for prevention activities out of PS. We are reducing overtime by 1 million in PS. We are reducing 2 more heads for $250,000 for agency needs in PS.
When you take the staff out of the equation, then the cost goes down also.
But PS is staff,
Yes.
right?
So
So
you're taking the staff out, now you don't have to pay the staff.
Yeah, but
So it works on both sides of the equation in that example. With hiring, so last year we had 500 plus vacancies. This year we have 161 vacancies. We're recruiting for probably double that number because we are ahead of ourselves, anticipating the turnover of staff. And so the efforts that we have done have really kept us in a good place with bringing new staff on board. One of the biggest expenses was nursing contracts and bringing in nurses per diem or on a nursing contract. That will come down because we're bringing the staff on board.
okay, so are your nursing contracts, I'm assuming you're meaning travelers?
Any kind of, right, like kind of per diem type nurse.
Okay,
yeah, that you
so
bring
are
in.
your nursing contracts in PS then?
Professional services.
They're in professional
They're on
services, not,
professional services.
not
Mhm.
personnel.
But it would affect things like overtime. So overtime is in PS. So as overtime comes down, as you have permanent staff, you're not asking the same staff to come in a mandated way and paying them double time.
Okay, so you're saying the 15.6 deficiency that you have this year, you're saying you're not gonna have a deficiency next year with these changes that we're making, not hiring those staffs, bringing in nursing, not having the nursing overtime, you're gonna be able to
Yes,
make
our
up.
goal is always to balance that budget, yes.
Okay. Thank you. The staff and client safety services here in OS.
Mhm.
Can you talk a little bit about what this is exactly? This
Sure.
is the security guards and panic buttons. Are these additional or are these new?
They're new. So we've done a lot of things. There's been a lot of discussion about safety and healthcare.
Yep.
And so we've done a lot of things to make sure that we're on top of that and anticipating any issues that might occur. So we have cell phones. We upgraded from flip phones to phones that have GPS in them. So we make sure staff always have them on, to sign in, sign out. A lot of different protocols to mitigate risk. One pilot that we are implementing would be to have panic buttons available to staff to be able to have with them at all times. So that's one example that would be paid for with these dollars. Another example is there are a couple of parking lots that staff have reported there might be people loitering in, or they feel uncomfortable walking through at night. And so we've made sure that we have some extra security guards in there to walk staff to their cars. So that is an additional cost.
Okay. And then I think the last question that I have is in regard to, I don't see them spiked out anywhere, but can you tell me what's happening with the recovery community centers?
Right. So that was an earmark, a federal earmark that CCAR received a couple of years ago I don't know if it's specifically, it did not come through DMHAS. I don't know what the terms of that earmark were, but they chose to open 3 recovery centers with those dollars. And the money is spent and they are looking for a sustainability plan.
Is that in here? Is that it's
No.
not under you?
No,
Okay. Do you know who that's under?
it was a federal earmark.
Oh, it's a federal earmark. All right.
yeah.
So, but if we don't have that money and they're looking for the recovery centers to be sustained, I would expect to see it someplace. So it's not in here. We're not going to be sustaining it with state
Well,
dollars.
this budget was released earlier in the month and this just came
It
out.
just
in the
came out.
news.
Okay.
Yeah.
Do you happen to know the impact of what it would take to continue those services?
All I can say is they did receive 1.5 million.
Was that for 1 year?
Yes.
Yes.
Okay. All right. Thank you very much.
You're welcome.
Next, Representative Dillon.
Thank you, Madam Chair, and good afternoon. I guess, well, the first question and would be for follow-up at the work group is we have the community response teams, which at least where I live, there's backup from the police department if a state employee goes out to a home where there's a crisis going on. Yes?
We have, there are different programs in different parts of the state, but we collaborate with the police all the time, yes.
Well, I guess my concern, because of an incident that happened with a private provider and the action that was taken, and I know that my co-chair, Senator Marks, was very instrumental in getting some legislation through, whether some of the safety measures apply to state employees who go to every town. Let's say if they went out in Orange, or is there an agreement with police departments in Orange and Woodridge and Bethany and so forth, or is that really up to the individual towns?
There are not, there's not a uniform policy, but there are collaborations in different municipalities. So, in New Haven, there's a strong network between Compass, 911, 988, the mobile crisis team. They all work together to ensure that the right people are going out to respond in the right way, depending on what the situation is.
I guess my concern, there are troubled families in the suburbs too. And I just wanted to know if we have any information about whether there's, I feel pretty good about what's going on where I live. But I don't know if that's happening in area towns Maybe it is, and I just don't know. There's a lot I don't know. But I just wanted to know if you could follow up and let us know.
Sure, I could say that I'm confident that the mobile crisis teams have been doing this for a long time. And I know in Senator Austin's area, there are different initiatives where mental health works with police departments. So it could be state police, it could be municipal police, but we have established those relationships over years of our work together.
Okay, thank you. And I know that I hate to keep going over this, but the prevention dollars, and obviously we're going to have to talk about it in the work group, but the prevention services, the positions are live bodies. Those are people who are going to lose their jobs. Am I right?
They could, yes.
Okay, so they're not positions really. They're people. I mean, they're positions, but they're people.
I believe we have one vacancy, yes.
Okay, and the grant accounts are being cut as well. And if we could have more information about how the cut to grant accounts fits in the big picture, that would be helpful. And I think that's it. Thank you very much.
Thank you. Representative Gilchrist.
Great. Thank you, Madam Chair. Good to see you and your team. I'll start where Rep. Dillon just left off. When you all come back with the prevention activities, can you give a breakdown of who the current grant recipients are when you come back? 'Cause it'd be good to know. And that's, so just so that I'm following, so there's 500,000 cut for the substance abuse services grants, and then 500 for the mental health services grants.
Correct.
Okay. And then those 7 positions, they're housed state level?
Yes.
Okay. And they oversee the grants?
Some of them are managers and some of them are not.
And so what are some other roles they take on currently at the department?
So there are folks on the cannabis dollars doing prevention work around that. Alcohol prevention, reducing alcohol use among youth. We have people that that oversee our tobacco prevention enforcement program. So a variety of different roles, oversee our federal grants.
It'd be good then too, when you come back to, if we could have an understanding of what those roles do.
Sure.
Thank you. Moving to the overtime. One of the other agencies in a different presentation was going to come back, so I would ask for more stuff, sorry. A chart on what the costs on overtime have been for the last 8 to 10 years, just so we can get a picture of, no offense, is this realistic? And also, since there are changes to staffing, it'd be good to know what the staffing looked like in those years, because if there's significant staffing cuts, then this might be realistic. So I would just, if you could kind of tell the story, where do you see the most overtime? What positions are those? Like, what kind of work is that?
It's going to be mostly at our large hospitals, quite frankly, or at a 24/7 facility. It's very difficult to manage 3 shifts. And that's one of the reasons why I would like to implement Kronos, because I'd say it's almost paper-based, but people have different spreadsheets and ways to manage scheduling and timekeeping, and this would be a sophisticated way of being able to fill those call outs as they happen in a way that's much more efficient than we're doing it now, which is with a person, with a scheduler. That's a lot of people when you think about all the beds that are at Connecticut Valley Hospital or Whiting Forensic Hospital. We also have inpatient facilities in New Haven, in Bridgeport, and in Hartford. So it's a lot of shifts, a lot of people. It would be the core nursing staff, and we consider that RNs, LPNs, and then our mental health workers or forensic treatment specialists.
Right. Thank you. And my final, did we move all residential addiction treatment services to the Medicaid waiver a few years back?
Yes.
Okay. And just wondering if you have the info now or could bring it back, what is the total number of available residential beds that we have today now under that waiver as opposed to before we made that transition?
We lost 84,
We lost 84.
but we're in the process of bringing those back
Okay.
in the areas that we need them. So the benefit, one of the benefits of the waiver is that we're keeping great data and we can see where the need is. And two areas of need that we've seen is halfway house level of care and what we call intermediate level of care. And so as we're bringing things up, we can be more informed in what we're bringing back. And that's also mentioned in here that we are reinvesting in the substance use system.
Okay. Wonderful. Thank you. Thank you, Madam Chair.
Thank you. So I pulled up, because I have I have everybody's overtime chart for the last 5 years, and I was just looking. And in 22, it was about 28 million for you. In 25, it's about 31 million. So it continually creeps up. Now, I know we've had contract settlements and things like that, so we've had those. But in looking at those numbers, I then look at the reduced overtime of $1 million. And then I think I listened in the conversations that you were having with, I think, Representative Nuccio. You said that it's been brought down tremendously. So did anybody ask for where the overtime is
In double time. So I believe it was 22 million and it came down to 11 million.
in double time? I'm sorry, I don't.
In double time. So that would be when somebody is mandated.
Yep.
So in other words, you're on staff, there's a snowstorm, we can't get the next shift in. So could you stay? And you are mandated to stay. You didn't really want to, but you have to as a healthcare provider. So in that situation, it's not time and a half, it's double time.
Okay.
And as we bring in more permanent staff, that situation doesn't arise as much because you have the staff available.
Okay. Now, would that be part of professional services or would that be part of personnel services?
Personal services.
Okay, so then I heard professional, I saw professional in here. So could you describe to us what are professional services?
Sure, those would be when we contract for services, right? So a nursing agency or a per diem person would come in to fill that shift. That was extremely helpful during COVID. And when we didn't, and then we were going through a workforce crisis essentially. And I feel like we are definitely over the hump with that.
Okay, so could you bring to the work group or just could you give us a list of all the contracts you have with professional services? Did somebody ask that? I'm sorry, I'm reading at the same time. So okay, because I think that would be helpful. And then the substance abuse and the I'll come back to you, Senator Austin.
Thank you. So we have, and I don't know, did you already ask the reducing personnel services?
Yep. They said 58 people.
Very good. I don't see 58 people being reduced, but.
I thought that's what you're.
58%.
Oh,
Oh, it's 58%.
That was just prevention.
Just prevention, the prevention piece, it's 58. That's the
Oh.
first one.
okay.
No, why does yours look different?
I can't tell you why it looks different.
The reduction in staff in this budget reflects also the move of the IT personnel. So
Okay,
that's why the number is.
yeah.
Yeah.
So the federal 988 suicide hotline,
Mhm.
this dollar amount here, because Representative Walker and I have over the last few budget cycles added money in for both 211 and 988. And I'm trying to, we were told that we were adding in funding that would support it 100%, that all three shifts, 7 days a week, 24/7. does this funding support 988 24/7?
This funding will allow us to do the second and third shift of text and chat. So that was when it was initially rolled out, that was 22. The requirement was to bring up the line. And so we brought up the line and staffed that 24/7. This year by 26, or no, by 26, we have to bring up text and chat for 3 shifts as well. We've already brought up the first shift within what we had available to us. This brings up the second and third shift of text and chat
For 988.
for
And
988.
you don't really do anything with 211. That's not your bailiwick, right?
No, although, all roads lead, so
Right.
people, if they call that, they can get to the services that they need.
Right, so we can be assured that if we should include this dollar amount in, that this is 24/7 for everything relative to 988.
Yes, we still do have ARPA dollars supporting that.
This
as
takes the
well.
place of ARPA dollars?
No.
So
it
how
doesn't.
much ARPA is supporting that?
We could certainly get that to you.
Okay, so it's not, we're not gonna come, when we come back next year, we're gonna have more dollars that you need to add to take the place of the ARPA dollars.
It depends on what we get for block grant funds, for example. So that could potentially support it. There's
Block
also
grant funds from whom?
from SAMHSA, from the federal government. There's also a grant that was put out federally to implement 988 that we're hoping is renewed. So there are many things in play. That's why I'm hesitating, because there are a couple of options on the table to be able to fund this service. It's not all general funds.
So, this is what always confuses me is that I want to add, I want to have a budget that we can trust. But when we're only given partial information, then I say we put the money in to fund something 100% 24/7. And you say yes, but we're using a lot of ARPA dollars after we get to the next question. So then I understand that it's not really funded 100% because ARPA is not full-time. So we are still going to have to add more money in. So we need to understand, if you could bring to the working group, how much ARPA is funding 988 and when does it run out? I know it runs out December of 26, but are you using the funds until December of 26? I don't know that. And then how would we fund after 26? What would that dollar amount be? So I want to, I want to make sure that we're asking the right question to get the answer that is comprehensive. So does that make sense?
It does.
And the opioid settlement, this budget includes 16 million in one year, 18 million in another year of the opioid settlement, which Representative Walker and I sit on. And we vote for those projects, but none of that's been voted on yet, right?
Correct.
So if we don't vote for those projects, say we don't like them, I don't know what they are yet, but say we don't like them, does that mean that that's a cut in services to people? Is it services that are currently being done by other dollars and we've decided to fund it now through OSAC?
Well, I'll use the example of mobile crisis. Yes, that is currently an ARPA funded service. Same on the child side.
On the child side, but not on the regular mobile
And-
crisis,
Yes, both adult and child.
are both being funded by ARPA, because we did have some general fund appropriations
you
for
did.
mobile crisis.
That
So,
is true.
You have the mobile crisis centers, mobile crisis systems in both adult and child, partially funded by the general fund and partially funded by ARPA.
Yes.
So let's take this through the next question then. Let's do the same thing. Bring to the working group the total amount of funding that is in the 2 different mobile crisis systems and, how much is ARPA, how much is general fund in each system? And what would it take to fund it? And when does that ARPA run out so that we know when we have to add funds to it? And, do you have planned, because it's clear that this is a plan, to, use OSAC dollars to do, programs in DMHAS, broadly besides what is in this 16 million and $18 million? They have some, she has some.
Okay.
Everybody has a piece.
I have planned to use to go through the OSAC process as we have been when we meet every other month.
Right, but my question is not that. I understand that we're gonna go through the OSAC process. I get that. This plan that's in the budget right now is an actual plan, right? It's an actual plan to use OSAC dollars. That's what we're doing. We came up with, we didn't, the governor came up with a plan, an umbrella to use OSAC dollars. And that was an actual thought out process. I'm certain that you were involved in the discussion about it at some point, because you have kind of the control over OSAC, you're the chair. And and if they didn't, shame on them. But are there other plans in that we don't know about yet on OSAC dollars?
Not that I know of. No.
Okay. Thank you, Madam Chair.
So I want to just go back to the mobile crisis vans.
Mhm.
They also get opioid settlement money too. We voted on that.
Oh, that's not mobile crisis.
That's not.
So there were two mobile vans
Yeah.
that deliver opiate treatment
Yep.
that were approved, but that's not mobile crisis. It's different from mobile crisis.
It's mobile crisis van, but it's not mobile
It's
crisis.
mobile opiate treatment programs. It's not mobile crisis. So if you call 211 or 988, they don't respond to you.
Okay.
That's strictly substance use.
Okay.
Yeah, regular hours.
No, that's
Yeah.
because I thought it was referred to as mobile crisis. So never mind. Nope. And could you explain to us, because I get a lot of people that ask me, when a request for funding is presented to us, where does it go and how does it get to the end result? Because there are two committees that it has to go through.
Three.
Okay, three.
So, different ways. So we had an open portal that we advertised broadly. People could submit recommendations that way. Since that portal did close, we have an email, so people can send at any time emails to the OSAC, as well as any of us receive emails with recommendations. So Louisa, Sarah, Chris, myself, we don't close the door on any recommendations. They come in. Then those are all compiled and they are given to the ADPC subcommittee. That is.
What is ADPC, please?
Alcohol and Drug Policy Council. And if it's a treatment recommendation, they may be asked to weigh in. If it's a prevention recommendation, then the prevention subcommittee weighs in. If it is a recovery recommendation, then that subcommittee weighs in. And it goes to the referral committee, which you're well aware of. So the referral committee, they're one of the key committees at OSAC. They look through what has been prioritized as an evidence-based practice, as something that is going to save lives, that is going to remediate the opioid crisis, and really look at that return on investment. What is going to be, for the dollars, what is going to save the most lives out there? And that's how they prioritize. That's why things like getting naloxone out there, saturating the state, was so important. And that's one of the ways that we were able to bring down the overdose rate from 1,500 to a little over 1,000. Still have work to go. Things like the MAT vans, the mobile treatment vans that you mentioned, that is another evidence-based practice where it's getting treatment on the periphery of Connecticut that perhaps did not have a clinic where a van can go reach that person and get them engaged in treatment. We've looked at hospital EDs. We had a hard time really spreading that evidence-based model where when people show up at the ED, the doc can induct them on medication right then and there and connect them to services, another way to save lives. Harm reduction centers and needle exchange that we worked with DPH on, that was another recommendation that was funded, a way to get people to use more safely. If they are using, let's save their life so that they have another chance at recovery.
And then they go to the opioid settlement council, correct?
And then if the referral committee says, yes, we're invested in this, then it's looked at fiscally, is this an allowable expense? It's looked at by the research team. Is this something that needs an evaluation? Is it something that's already has a proven track record? And once it passes all those hurdles, because we want to make sure that it's evidence-based and proven, that we can afford it, and that it's an allowable expense, then we vote on it.
Okay. Now, people don't, okay, there's the the Alcohol, Drug and Policy Council. Then there's this, the OSAC committee, the Opioid Settlement Committee. And you said there's a third one. What's the third?
Research.
The
committee
research.
And the fiscal committee, yeah.
Okay. Well, the fiscal committee is in the OSAC.
Yep.
Oh, okay, I see. You're counting a couple of the
So,
committees. Okay,
8.
all right, got it. Because people ask all the time, and it's something that I get questions on that over and over again, and maybe there's got to be some sort of simplistic diagram so that people can see it, because
we do have it.
yeah, I know, it's a little, it's got a lot of arrows. It's got a lot of arrows. But I think something has to be sort of created so that it's a little bit more understanding for people, because people have some great ideas, but they don't exactly get it to the
Yeah, I think there's a misunderstanding that when you send an idea in, it's an application for funding, and it's not an application for funding.
Yeah, it becomes a little bit more difficult. Representative Dillon.
Thank you, Madam Chair. And for the second time, I forgot to ask, when you're bringing any information about overtime, I wonder if you could provide for the work group information on overtime trends and caseloads at Connecticut Mental Health Center. I know they have an outpatient emphasis, but there's also an inpatient, a 24/7 facility where very often the women who work there would be asking over the years about safety when they were coming out in the parking lot. And so I just want to make sure, I want to see that facility is disaggregated when we're looking at trend lines to see what's going on.
Regarding
if you would.
Overtime? Is that what you mean? You're asking for
Overtime and caseloads. Because there was, well, we won't get into a discussion about that, but yes, caseloads and overtime.
Okay, caseloads for outpatient providers, is that what you're?
Yes, and overtime in the aggregate for both. Thank you very much.
Thank you. Representative Kennedy?
I'm all set.
Oh, you're all set, okay. Representative Gilchrist? Okay.
Thank you.
Senator Austin? I'm all set. Okay.
Thank
You're getting out quick.
Oh, all right.
But the one thing that I will ask is one more thing. Can we get with the OSAC, they have categories of things that types of funding that is available for people when they want to submit things, and it's either recovery or something like that. Can you give us those categories at the subcommittee meeting? So that,
I can say them quickly now if you'd
okay,
like.
sure.
So harm reduction,
Mhm.
prevention,
Mhm.
treatment,
Mhm.
and recovery.
Okay.
That about covers it.
And when you state those those four, is it, is there more definition that is behind that? So when you say harm reduction, how, there's a lot of harm reduction.
So there's actually an entire exhibit. It's called Exhibit E, and it's pretty comprehensive, and it details every allowable use under the settlement.
Okay, is that part of the settlement or is that part of the state statute for the opioid settlement?
Settlement. And there are more than one settlement. It's complicated, but this is an exhibit that has been used by most of the settlements.
Okay, okay, so it would, if you could send that. 'cause
Sure.
They're gonna call and ask for that.
Yep.
We're gonna ask for that too. So that would help us a lot too. I'm trying to think of anything else when it comes to the opioid settlement that we, maybe sending in where we are with the funds that we've submitted already, the ones that we've drawn down, the ones
yeah.
that are in.
We have that, yeah.
Yeah, I think that. I'm just trying to remember some of the questions that I get on a regular basis. But those would
Okay.
be good.
Anything else, just reach out.
Yeah, we will. We will. Thank you so much. Thank you. Have a good day. Thank you. All right, that concludes the morning portion of our day, or early afternoon. We will reconvene at 4 o'clock here for the public hearing. And same time, same channel. Have a good